exercise. We have given you, all of you have been given a Cath course as an exercise. I hope you have found it. The answers are also there in the Satyasai notes, and I would have expected that you have gone through the things. Now, can anyone tell me why a Cath course is done? It has to be interactive. It's not just me talking. Why do you think a Cath course is done? Yeah. But why all this trickery is done? I will call it. Why is it done? See, you said yes. There are diagnostic Cath courses which will give if you have a diagnostic Cath course, it is the diagnosis is obvious. But why?
Uh, by doing an angio, you are going to put in more dye in the patient.
Yeah,
Suppose it's a
you need
pediatric
to
patient.
limit the amount of dye. Suppose it's a 3 kg or a 5 kg child, you can only give 10-15 ml. So you will only guide the Cath to what is required, and you will not waste your time on doing things which are going to consume but not give additional information. Today, especially with echocardiography being so good, 95% of the cardiac catheterization is not done compared to what when maybe 30 years back when echo was not good. So today it is a very, very, very directed cath, and so you will try to cause minimum hemodynamic stress to the child. Remember, contrast given, injection into the LV, all these things can cause hemodynamic instability, osmotic overload, cardiac failure, and contrast induced problems. So we want to limit it. So today with the diagnostic cardiac catheterization, especially in congenital heart disease, has sharply come down. But in but there is a role in every case. For example, today with echocardiography, we don't do commonly an LV angiogram. In coronary angiograms, you don't see them commonly doing because they want to waste, and also injecting into the LV is not without its problems. So, as I said, reduce the quantity of dye, and diagnostic Caths are self-explaining. Now, how do we go about doing this thing? Now, we have to determine whenever in a Cath course whether it is a arterial catheter or a venous catheter. Now, the most important part of an arterial catheter is it never has an end hole. If you have a catheter with the end hole, it is not an arterial catheter. Can you tell me why arterial catheter never has an end hole? Yeah.
So it's in a very high pressure system. So it will cause intimal injury.
Now, when you put a contrast into an arterial catheter, you are going to have to put a sufficient pressure in it such that it has to overcome the pressure, arterial pressure, to be able to spread the inside. So, and it has to be rapidly given. Now, that catheter, if it abuts the wall of either the artery or the ventricle, it will get intramurally injected, and if it is in the artery, it can initiate a dissection, and if it is in the ventricle, it can induce fibrillation. Okay, intramyocardial injection can induce fibrillation. It's an irritant. So now, so that is the first thing. So usually a pigtail is used, and in sometimes there are other catheters like an NIH catheter. But remember, the NIH catheter has got a side hole. It is a straight catheter, but with a side hole. But none of the arterial catheters have, and the pigtail is one of the safest catheters because it is round and floppy and it won't go in. The only problem of a pigtail is to negotiate orifices. You may have to straighten it temporarily by putting a wire and then using it. Typically, no arterial catheter is placed without putting a guide wire, confirming its intraluminal presence, and then afterwards the guide wire is removed and it can be advanced as required. Now, the common thing, what do we see in a cardiac catheterization? What can we see? We can see the catheter, we can see bones. So what are the bones that you can see? You can see in the center spine, you can see clavicle, and then other shadow that you can see is the diaphragm. These are our landmarks. So whenever you're describing, it is below a catheter going from below the diaphragm on the left of the spine or the right of the spine, it's the arterial catheter going from, you surmise because it is a arterial catheter that it has been put through a particular vessel which is closest to it. And then when it goes up and takes the course, it has crossed the diaphragm, it has gone into this thing, it is outside the cardiac silhouette or within the cardiac silhouette. Outside the cardiac silhouette means it is a structure which is, I mean, obviously outside the cardiac silhouette means it's outside the heart, but it means a catheter going from within the heart to the outside the heart means what are the structures that could come? Pulmonary artery or pulmonary vein. Depending upon the position, we'll have to take the call about the course. So you have to keep remembering in your mind. So how does it course and is there any diagnostic course? So we will be giving the live exercises. I've given, come, you've all been given the exercise, right? Come. One by one, 5 of you come. 6 Cath courses were asked to be found. Have you done it? Why? Come. Where is the question paper? The question
No,
paper?
you can tell the diagnosis, they have to explain.
Yeah. Okay.
You go diagnosis.
Normal Cath course into the RV.
Normal cat goes into,
RV.
this is what doctor
Different pen.
or you want commenting. Bony landmarks.
Come. Manya. I had actually asked all of you people to.
Not visible.
Marker pen, please. Marker.
Put some spirit. Whole idea is this should not be visible. This is just the background of the chest. What Prasanna sir was telling, background of the chest and with spine and vertebra. This is all that you see. Okay, and this is the catheter.
It's writing. Now come. What is Take the mic. Take the mic. Can you focus on this? Yeah.
When we enter a vein, we see the cat. What's the question?
First, determine the tip of the catheter. Arterial catheter or venous catheter?
It is not pigtail, it is a venous catheter.
Okay, so we'll direct the venous catheter. Okay, so now from there is it going?
It is on the left of the spine. It is going through the right of spine. It is IVC. Sir.
So IVC to the right of spine. Conclusion.
Venous catheter.
Yesterday, we are persistently saying every word you speak should tell you something about the diagnosis. So etiology, mechanical problem, pulmonary hypertension, sinus rhythm, NYHA status, complications. So something of this sort you must try to achieve again and again. Okay, catheter has crossed the diaphragm. Can you mark that part? And that part is where? Above the diaphragm. Bus. What is this part? Which chamber?
RA.
RA. Okay. So don't try to create too much complications by cavo-atrial junction. Okay. We are in RA. Next, what it will cross? Tricuspid valve. So tricuspid valve is to the left border of the spine. Left border of, she's confused about left and right. Just put a mark, put a cross over there, please. Nice cross. See, this is for the world to see. Okay. So don't put a mark which you can only see in Muddenhalli. Okay. And then the catheter pass further, touches the diaphragm. See that catheter goes down and touches diaphragm. So this is a chamber on the left side which touches the diaphragm, and that chamber is right ventricle. Okay? Now, Prasanna, can I add with your permission? Moment you see this, you stop thinking. Now suppose the contrast is injected from RV. What are the chambers it will go through? Naveen, na? What's your name? Harish. RV body. Next, where the contrast will go? Before that, infundibulum. So you are a surgeon, man. So it will go into infundibulum. Then pulmonary annulus. Then pulmonary valve. So all these structures you have to comment upon. This is classically the angio in the case of tetralogy of Fallot. Okay? And then MPA and the branches. Okay? So remember, first of all, you ask yourself, what I am going to see next. And suppose this is tetralogy, then where else the contrast will go? Through the VSD into the either LV or LV and aorta, according to aortic override. So every frame tells you a different and knowledge about the case. So don't set away, say it will go to, thank God you did not say goes to kidney for filtration. So that will be the ultimate of everyone. Okay? So next Cath course. The previous one is still seen on the view. Yes, answer Prasanna sir's question.
What is different now?
Describe in simple English.
Next candidate.
We see the cath coursing to the right of the spine, crossing the diaphragm. Venous catheter crossing the diaphragm. Then
Crossing the vertebra.
crossing the vertebra,
But at what
going to
level?
the left side.
But at what level?
Compared to the previous thing, is
It
it
higher.
In the right
It is higher.
atrium. What are the ways of going to the left side of the spine? One is through tricuspid valve into the RV. Second,
ASV.
ASD into either LA, but it is again touching the diaphragm. So through ASD, mitral valve and reach the LV. Okay? Prasanna, correct? No, for him. Thank you very much.
Sir, the course of the catheter is from the femoral vein.
All of you, please write down the format of talking. You have to start with that.
Yes, sir.
You start at cover point or square leg. Square leg. Cover point, you may fall beyond the boundary or pull the. Yeah.
Sir, the catheter, the
Venous
venous
catheter.
catheter.
Venous catheter.
Venous catheter going
Give one
through.
mic to Dr. Prasanna. Murli, give one mic, Dr. Prasanna on mic.
Sir, because it's
Just
traveling.
now Prasanna told.
It's traveling on the right of the vertebral column, so it's going to tip of the catheter. Yes, sir. Venous catheter. Yes, sir. Sir, the venous catheter is traveling from the femoral vein to the IVC, and then
IPC to the right of spine.
to the right of the spine, and then it is going into the right atrium.
Crossing the diaphragm.
Crossing, you describe what in simple English.
Yes.
Then crossing the spine
Crossing the spine.
at low level, high level, mid level, high level. You
Yes.
opine something.
crossing the spine at approximately.
I forgot to draw
Yeah,
this.
this
I'm
is
very
that.
sorry.
Yeah.
My mistake. Crossing the spine at a higher level.
At a higher level.
You are still seeing the previous crossing
At a lower level.
at
sir.
a lower level,
Lower level.
This was at a lower level.
Yes.
which
This
you
was
said
at a
was
higher level.
tricuspid valve.
Tricuspid.
Correct?
Yes.
Now
sir.
this is at a higher level, which just now you only answered
Uh,
across the
yeah,
ASD.
It is across the ASD. Yes. Sir.
And then what has happened?
Sir, going across the ASD, then it will go into the left
Hey,
atrium.
don't look at him, look at a catheter.
Sir, across the ASD, it will travel to the left atrium.
Then what has happened?
Where the catheter is lying,
I don't know whether it is left atrium. Is it written there left atrium? How do I put
where the
that?
catheter is lying.
Can you see something? What did I tell?
Just
It is-
now he told you.
There is shadows, there is bones. What is the sir actually said? I am sorry, I forgot to draw it.
I have drawn cardiac silhouette. Does it look like cardiac silhouette or some Picasso picture?
What is this?
Cardiac silhouette, sir.
If it has it gone outside the cardiac silhouette?
Pulmonary is the
What
pulmonary
pulmonary
vein.
what?
Pulmonary vein, sir.
So which pulmonary vein?
Sir, right superior pulmonary vein.
Arey Baba, these guys have right-left dissonance here.
Confusion about right and left today
This is
morning.
a patient in the cath lab. Is this right or this is left?
Sir, this is the left side of the.
So how can it be right?
बोल रहा है आप उसे
That is pulmonary.
Okay. Sir,
So gone. This is the only proof the catheter has gone through LA because it has gone outside the cardiac silhouette into the left middle lobe pulmonary vein. That's the only proof. If it is lying somewhere over there, there is no proof it has gone outside. Okay, it has gone into LA. Remember, as Prasanna said, there is no board to tell you that this is LA. We are just imagining.
next one, be ready. Come.
Or you can come from here also.
Yeah.
Show your willingness to. He is
Now-
waiting
now,
for to be invited.
Instead of going like this, it is going like this and gone outside the cardiac silhouette.
Chalo.
Oh, I shouldn't get like that. Yeah. He-
Tambi, mela po. Paak mudiya deno ka. Patient.
Tell me. तेरा चेहरा
My dear, can you speak English?
Yes, sir.
So describe in simple English. We don't want George Bernard Shaw, Shakespeare, Shashi Tharoor, not required. You just describe.
Where
Just
is
now
the
we
cath-
said, this is venous catheter, arterial catheter.
Is it venous catheter or arterial catheter? What did I say? You were not there.
So
Oh, that's why. Look at the tip of the catheter.
Yes, sir.
If it is an end hole catheter, it is a venous catheter. Arterial catheters are all side hole, typically pigtail today. We're not going to too much. But now, so it is a what type of catheter?
End-hole catheter.
So what will it be? I just said now, venous catheter. So the
sir.
venous catheter,
Yes, sir.
from where has it gone?
So from femoral vein,
Of
side of
IVC,
IVC,
to the right of
right
the,
side of the vertebra,
then
crossing the diaphragm,
and
then
What chamber will be
RA.
that?
what chamber is this?
sir, RA, right atrium,
Right atrium. Then
sir, then SVC,
Then where did it go?
again
Sir,
gone
right
out of
out of the-
cardiac silhouette.
sir, right superior pulmonary vein,
Very good.
So what is the diagnosis?
So stop, Tambi. Look this side now. What are the ways of catheter from SVC or RA? I'm giving a hint.
Hint.
Going into right superior pulmonary vein. What are the structures on the way? Others can also answer. I will repeat on the phone, on the mic. Through sinus, very good. Through sinus venosus ASD into right superior pulmonary vein. One course. Any other course? Directly from RASVC into right superior pulmonary
Vein.
vein. Understood? I'm very happy. What's your name, dear? Aniket, excellent. All that you have to just know little bit of anatomy. Cath course is all knowledge of anatomy.
It has come back into use. It in between we
Oh, really?
stopped using it. Now again it is coming back into
Very
use.
good.
So right inferior pulmonary vein.
No.
It is still within cardiac
It is
cilium.
within cardiac outlet and is pushing. And I've just given a hint. I've actually given you a hint.
It is, what is this chamber?
Sir, right atrium, sir.
Right atrium. So suppose the cardiologist, the interventionist wants to inject in right atrium, where will be the problems, you think?
Coronary sinus, sir.
He will inject in the coronary sinus, no?
Why will he inject here? He is
Right
putting
atrium.
and he is holding it there.
Lateral direction.
Ah.
Forget lateral direction. Right atrium. So from right atrium, the contrast will go. One choice is
A. Left atrium, sir.
tricuspid valve
Okay, tricuspid valve.
into RV.
RV.
Number 2, ASD.
ASD.
Correct?
Left atrium.
So why a person should inject in right atrium? Any other cause? He may not know.
Yeah.
He should be
Okay.
pardoned.
Yeah. Now he is trying to push here and it is the cardiac silotus here. What is inside? What is the structure inside? RA
RA.
valve. And what is outside?
Pulmonary veins.
No. Pulmonary vanilla. The sill out.
Sill.
So what is in between?
It is not touching the edge of the shadow.
There is,
What
there
is the
a
structure?
distance.
Between the lung and this thing, what are the structures?
Pericardium.
Pericardium.
Sir.
So if I have a thick pericardium,
Pericardium.
so
Constrictive
constrictive pericarditis.
pericarditis.
Yes, sir.
One.
This one.
Thank you.
We'll keep it straight, sir. Clavicle.
Another structure I forgot to draw. Chal beta.
What's your name?
Saurabh.
From?
Sir, Lucknow,
Lucknow.
SJPGL.
Hmm.
Sir, straight tip venous cannula catheter, crossing diaphragm and going towards left side at this level.
Describe the left side.
Anything?
Simple English, describe the left side.
So through RA to
No. Catheter course on left side.
yes, sir.
In simple
Something
English,
very
please describe.
describe.
See, this catheter also went. This catheter also went on left side. This catheter also went on left side.
Yes, sir.
This catheter is also on left side.
But
So
there is something peculiar.
describe in simple English. Don't worry about the medical part.
And don't go one step back. Come for it.
So, clavicle.
Is the course
Don't give
Parallel to
parallel
something.
answers.
is the course parallel to something?
Parallel to something.
Parallel to spine, sir.
Parallel to spine.
And then what happened?
Which border of spine?
So left
Left
Border
border
of spine.
Then what happened?
Then it is crossing the clavicle. I said I forgot to draw
Draw.
Yes.
clavicle. So clavicle is a landmark of what?
What does clavicle mean to you?
Thorax into neck.
Neck.
Yes.
So what does it mean if a catheter has gone from the heart into the neck? Means the structure has to have a cervicothoracic connection. What are the things which could have a cervicothoracic connection?
on the left side. So LSVC.
LS we see here.
Left.
Okay. So it's a venous catheter which has gone out into this thing and it will be a left
Left
Just
superior
just
venous cava.
suppose a contrast is injected.
Injected.
Suppose
Yes, sir.
a contrast is injected at this site. Don't look there now. You
Yes,
have
sir.
seen.
Yes, sir.
Occipital job is over, not temporoparietal job. What a cardiologist or angiographer want to show you. Suppose at this spot, contrast is injected.
Here.
Something important to you, surgeon.
Sir, LSVC presence will be.
Sorry,
Sir, LSVC presence will be.
less is the present.
Yes, sir.
But the management changes if something else in addition is present. इससे ज़्यादा hint में नहीं दे सकते. It's as good as giving the full answer. Yes, Siddharth.
Sir, left innominate vein.
Whether the left innominate vein, bridging innominate is present, and if present, the size. And if the surgeon feels that the bridging innominate is adequate in size, cannulation of left SVC won't be required.
Also show the unroofed coronary.
Unroofed coronary. How will you know that it is an unroofed coronary?
Unroofed opens where?
Sir, in LA.
LA.
Yes, sir.
So what?
Contrast
That
will come
contrast
in-
will go where?
LA, sir. Will come.
LA from LA to
LA to RA. So,
LA to RA.
LA to-
Agreed.
But then
Then LA to
LV.
LV.
Yes, sir.
LV to
Aorta.
aorta. And when it reaches aorta, you will know.
so you would not see an arterial this thing in the next couple of beats if it had been roofed.
Yes, sir.
You understood? Okay.
It will
But-
come directly to.
Now next person. They keep coming in a row. No, it should not be an invitation.
सबको invitation देना. चलो यार.
बीच में से नहीं है, the corner, no point sitting in the middle. Everyone trying to get the line. Let that come and sit here, sir.
Through the
आगे बैठो.
through the
आगे बैठो. Just sit here.
इतना complicated.
I will give I'll state him. PD.
So remember, this is the cardiac sealer. This is this. This is this. This is the right heart catheter.
That green pen, give that. Blue pen got fallen down. Give this. This is permanent. Sir. Yeah, everything's permanent.
There's 1 year on the table. No, that is the one which is not.
This is absolutely
Important.
classic. May not touch here.
Yeah.
Like Devanagari
Ta.
Ta. Tamil Karan. Tirumai To.
Sir, this catheter is going through IVC into a
Venous catheter.
venous catheter
Ah.
into a RA.
Ah. Then
Then
Mania disappeared.
That's a new course. This catheter passes through septo anterior ATL STL commission. From RVOT, it straight away goes into RVOT. Normal catheter doesn't go into RV apex. It goes from anteroseptal commissure directly into RVOT. Can you imagine which part must be RVOT? Excellent, excellent. Write it down. What are you worried? Correct? Then what next it will go in line with RVOT?
pulmonary artery, sir.
Very good.
Correct.
MPA. Pediatric surgery make you told you. Don't say pulmonary artery.
Then what?
For them, pulmonary artery is a huge. My
Ah,
dear,
then?
what's your name?
Sagar, sir.
Sagar. Forget that now. Now come to the left side of the spine. So what that structure is?
Descending thoracic.
Fantastic. I like that word. There will be abdominal aorta.
Abdominal.
It is below the diaphragm.
ATA here.
Very good.
Ah.
Write it down as abdominal aorta.
This is-
The world is seeing you.
Ah.
This is new short forms. Kya? AA. And ascending aorta is what? Abdominal aorta.
Ah.
I didn't tell you that joke. One more joke about short forms.
Okay, then
Okay. So now you tell me how a catheter in MPA reaches descending
thoracic aorta.
thoracic aorta, abdominal aorta.
PDA, sir.
Thank you. Understood this?
So this is
Do you require intelligence for this?
Huh? PDA.
Just
Now,
knowledge of attachment, logic.
now I will ask you a little this thing.
Bus. Cardiologist is trying,
Trying to do
trying, but not going below the dome of diaphragm.
He cannot push it. Same thing is happening.
That is the DD. You are absolutely right. What your name you said?
Sagar, sir.
Sagar, you are perfect. But now this time, an expert cardiologist trying his best, but the catheter not going below the dome of diaphragm. So what is that structure which starts from MPA but doesn't go below the dome of diaphragm? Simple.
What would it be? It went into the pulmonary.
The pulmonary artery, the right.
Sir, I seek IACTS permission to throw them out for constantly confusing right
Right
and
to
left.
left.
We are left with no choice. Am I right?
Yes, sir. Yes.
He's talking about his right.
This is a patient, no? This is a patient,
For
no?
all anatomical diagrams, you have to put this thing here. Right? There. Superior, inferior, or caudal.
Yeah, but here now we are doing in a Cath.
This is
no?
X-ray. This is Cath on table.
On Cath, this
So
is
if a
not-
cardiologist, the catheter goes behind the cardiac silhouette, but doesn't cross
Cross.
the diaphragm, it is
LP.
LPA.
Remember,
Understood? Sagar,
Yes, sir.
this is
you are perfect. I'm very happy.
RPA is at right angle sitting like this. LPA is
Behind the
behind.
cardiac silhouette.
Sir, but the catheter will go from
It is
MPA to
MPA coiled and going into LPA.
A vessel which courses like this down.
If your confusion, I will try my best to solve. Is this a better one? If you see lateral view, if this is MPA,
No.
yesterday I showed you, same direction is PDA. But behind like this is
LPA, come here.
LPA.
This is
okay.
RPA. Ishvara sitting with Parvati and catching Skanda, Ganesha behind, dragging him behind. What are you seeing? Can you see the LPA? Now imagine a beam going and hitting. So here his hand is on Parvati and his other hand he is dragging Ganesha or Skanda, I mean whatever, Kartikeya, whatever. So he's having like this. Okay. Or somebody.
Yesterday, supracardiac
Supracardiac
TAPVC, yesterday he already
done. Can
answered.
anyone can somebody draw the supracardiac TMPVC quickly because we have to go down to 10 minutes we are keeping for each section.
Okay.
Yeah. Not so parallel. Just imagine, no, if it is in.
It has to go behind the heart.
Ah.
Just now, where did we draw left SVC?
No, left SVC is parallel to.
Where did we draw left SVC?
Bridging where? Parallel to the spine, then
forcing towards the right.
Embryologically, left vertical vein is left SVC. So where did we draw left SVC? So vertical vein will be there.
Not that far, parallel to the spine.
No,
Parallel to the spine like this, and then it goes into the chamber. Then it can go up, it can go down, it can do anything it wants, but it goes
Towards the
outside the cardiac silhouette. You must remember he has pushed it out to show that it is a.
So these words like outside the cardiac silhouette, below the dome of diaphragm, right heart catheter, SVC, IVC location, you should be able to tell that these are the secret words which tell the examiner you clavicle, going above the clavicle.
The last one.
समझता नहीं मुझे भी. You have to rub out the earlier ones.
One catheter is to the left of the spine, other catheter is to the right, and the two catheters are not crossing. One is a this is the arterial catheter, and this is the venous catheter. And the two catheters are going like this, but they are not coming parallel. What do you think it is?
First, normal left heart catheter. I request you to first normal left heart.
To the right of the spine, to the IVC, to the RA, through the tricuspid valve, into the right ventricular apex. Then this is the arterial catheter because it's a pigtail, forcing to the left of the spine, forcing to the descending abdominal aorta, crossing the diaphragm, descending thoracic aorta, crossing the arch, ascending aorta, through the aortic valve, entering to the LV, then through the LV, entering posteriorly into the LV chamber, into up to.
Normally, how would you think this catheter should be in you and me?
Sir, anterior or posterior?
If it were LV and you're correct. This thing, how would it cross? It would cross and
Cross.
it would have crossed.
Behind
Normally, it would be crossed.
Yes, sir.
Like this.
Yes, sir.
But it is not crossing.
Yes,
So
sir.
it means to say that this is lying on the, so it tells you that the septum is
Deficient.
not deficient,
Yes.
it is this plane.
Okay, sir.
Normally the septum
Okay, sir.
should be like this.
Yes, sir.
Instead it has become like
Yes, sir.
this.
Yes, sir.
And so this is
Malpost.
Huh?
This is a aortic override problem.
You may not know this, but this is a CTVS.
Okay, sir.
Okay, remember that this is a classic, this thing, if you see this, it's a CTV. Okay, because now we have finished 10 minutes for this. Now, because we can't complete other things. So now hemodynamic studies, everyone must know the normal values, the normal waveform. Next candidate come, please. Somebody come. Normal waveforms. Now you have to draw for me a normal atrial trace, a ventricular trace, and a atrial trace, a ventricular trace, and a great arterial trace. Come. See, we should not waste time. The more I will stop it with the moment Hiramat tells me to stop. 15 minutes, we are wasting time. Come, run. You are all students, no? Then come. 4 of you come.
Come forward.
Quick.
Sit here.
I want
Participation will make you learn more. Think you are not going to learn anything. Participate, make your mistakes and learn.
see, if the last thing I'm actually discussing is angios, because every day you are seeing angiograms. But this is what you all miss out. Come, stand here.
Remember the army principle: sweat during peace, save blood during war. So this is peace. Sweat during peace.
I always tell better to be a fool in the CME or in the classroom rather than fool in the exam. The price paid is different. 6 months of your career.
This is 0. This is how you show your maturity. Okay. Arterial pressure.
Quickly draw atrial wave.
Atrial.
I said atrial wave, ventricular trace, arterial trace.
That's why, sorry. Atrial, that's why I drew.
Let him do it with this awareness.
We can adjust.
They'll adjust to that requirement.
Changing the scale.
No, that much 100, sir, is written.
Okay.
I thought arterial. That's why.
Okay, we'll just put this as 100. Make that 100 and draw. Make it 100. This is 100, man. Don't try 10, 20, 30. Just draw.
Very good.
Now draw. Yeah, that's enough. Don't rub anything.
Okay.
Now.
Sir, arterial trace, RA pressure or L.
Atrial trace. Just draw atrial trace. Now draw ventricular trace. Yeah. Atrial trace, now ventricular trace. I am pushing the catheter, it goes into the ventricle.
Ventricular trace. What is the classic of ventricular?
Is it like that?
The first one is not ventricular. Second one looks more ventricular.
Sir, it is more square, like more
Square.
more
Yeah.
broad base.
The during diastole it will touch.
It does not touch zero, sir.
No. Please remember, blood.
Diastole ventricle touch what? Pressure will touch what?
Blood has to flow from always from higher pressure
Zero.
to lower pressure.
Pressure is of 20.
I will tell you something. Can water come up the pressure trace passively? This is diastole, no, atrial filling. Now, can blood go from here to here? Can it go uphill?
No, sir.
So it has to come down.
Okay.
Go down.
Actually, RA and RB are one chamber.
Go down.
Okay.
And actually, strictly speaking, it
Minus.
forms a minus and then comes up like this. Okay.
Yes, sir.
That we will call later.
Then arterial.
This is called as dip diastole. Okay. Then next it goes up, and then now it goes up like this. And then next, I want the next bit to go to the artery. See, I'm not using PA. I'm just using the term artery. Now make it go to the artery.
Perfect. Perfect.
Can you tell me what is so what has happened here? What is this?
So there is a valve which comes in between. So the
Semilunar.
pressure.
So this is the diastole. What is this you are drawing?
Diacritic notch.
Okay, now I'm just going to ask you, because this is in the ICU, you see this every day. There is because it's got a clinical importance.
Take just one question.
Uh.
Suppose you are shown two tracing like this. One ventricular trace, which immediately becomes arterial trace, or vice versa. What immediately will come to your mind?
Ventricular trace becomes arterial trace, then it suddenly flips back to the ventricular trace, and then I think I literally, if you are sharp, you would have got that.
You can compare the peak systolic pressure.
If you have drawn this, what does
Peak
actually it shouldn't be there.
pressure.
It should be like this.
Okay.
So
Normally, peak systolic pressure should be ventricular and
arterial should be
equal. Okay.
Okay.
Yes, sir.
Okay. Suppose there is a vast difference of say 50 millimeters. What are you diagnosing? Aortic
Stenosis, stenotic lesion. Stenosis.
Now I'm just
immediately your mind should be checking where is this, where is this.
now I have two arterial traces. One is looking like this, one is looking like this. Comment. One is looking like this, the other is looking like this. What do you think has happened? What can you surmise about the hemodynamics of this patient? This is used in the ICU. All of you should be seeing this in the ICU. Are you happy with this trace or this trace?
This one, sir.
This one. Why? What crime did this do?
That diacritic
What is
notch
that?
has passed down. The diacritic notch has come down.
Hypovolemic status of the patient.
No. The dichrotic notch has moved down. It has come here instead of here. Here. What does it mean if the dichrotic? What does the dichrotic notch mean? Closure. When the ventricle ejects, the dichrotic notch is closing prematurely means what? It not low pressure, that the vascular resistance is so high that it is slamming the door back.
Increased
Understood?
systemic vascularity.
I have ejected. I need the capacitance vessels to dilate and get my go into the thing. But no, I am banging my head against the wall and it's closing the valve. So if you see a high dichrotic notch, the patient is cold. If you all of you go back after cardiopulmonary bypass, see the thing, and after giving a vasodilator or after a few hours after cardiac surgery, you see this. If the same thing keeps moving up again, it means the patient is vasoconstricting. Please remember, the very practical thing. Next, now
5 minutes over.
Yeah.
I will just give one quick quiz.
Yeah.
Diagnosis. Spot diagnosis.
This was
What are you seeing? Atrial trace.
Atrial trace, yes.
And the cardiologist has passed from ideally
RA.
LA to RA. Ideally LA to RA. That is called pull back.
Back technique.
So suppose it is LA to RA. And what you find? Pressures? Pressures are?
Higher in the LA. In the RA.
Okay.
not
I
hard.
meant,
Okay.
I meant to be equal.
It meant to be equal.
I got tired.
They are within 3 millimeters of each other. I'm going to tell that.
Equal.
Equalizing
Then
pressure could be atrial.
not could be.
It is atrial chapter.
So in the
ASD.
exam, equalization of mean and phasic pressures is a
ASD.
ASD. If
Understood.
they are not equal, and still it is happening, what is it? I am pushing from, I am withdrawing from LA to RA, but the atrial pressures are higher than normally atrial pressure are higher, or which we will go that later. If I can pull it back, but there is a gradient, what does it mean? If I pull back between any two chambers and I find the difference, what is it called as? A gradient. Now there is a gradient between LA and RA, but I have managed to push my catheter through. Means
So
what is it?
What is that? By push, he is telling you the size of the ASD.
Don't restrict your answers to some things.
Restrictive
ASD.
Which is the famous restrictive ASD?
Which is the most common restrictive ASD?
patent PFO. Patent foramen.
So it could be a PFO. Now remember, same way VSD can be a restrictive VSD if the gradient is more than 10 millimeters of mercury.
Chalo, 5 minutes over.
5 minutes over on this.
Next.
I will give you the things. You can see all these are questions which you should be knowing in Cath, but I have not been able to discuss them. Can you put the Cath? Can you put? So you must know what is zeroing of a transducer, damping of a transducer, what is peak to peak gradient, and how is EDP measured, what is wedge pressure, balloon occlusion pressure, and transpulmonary gradient. You must know all these things. These are questions which you can go home and study. This is the famous Vigor's diagram. Those who had attended the conference, I had shown the photograph of Vigor, and that was a question. We had put the photograph of Vigor and asked what is his contribution. So you must know, see here, you must know where the QRS, and today in 2025, you must not only have this, in addition to Vigor's diagram, you must add echo Doppler to this. Modern day, this thing is to have Doppler superposition on this, not just this much. Now, we have just described ASD and PFO, non-restrictive VSD, and diastolic dysfunction. How do you diagnose? We talked about this, no? There is a thing called as the ventricular trace. This is not the dip. You don't go to that full dip, but it forms like this. This is the EDP. Normally, which is higher, LV EDP or RV EDP? Why? Not because it will sing. You come here. And Manya is usually the person I keep. Now he do this. Okay, you can do with him also. Do this. Now come here. If I do this, okay, he's also been exercising. And this thing. Now who will be softer? Usually I put a girl and a stiff myocardium, LVEDP. So compliance. Okay.
LV compliance is
less. So diastolic dysfunction. Then another important thing that they will ask you, because we have to go quickly, we cannot. This trace, if you are ventricular, what is this trace? What is this trace? What is this type of trace? This is called a square root sign. The EDP is high. It is there also. So you must know this, and there will be equalization of all the diastolic pressure, atrial pressure, all will be the same in which condition? Constriction. They will ask you things like differentiation between constriction and restriction. There is a ratio. Please read it up between the systolic versus this, what percentage. But we'll not have time because we are running out of time. The next. Now, please remember that today the question that is being commonly asked today is, why do you use peak-to-peak gradient in Cath and mean gradient in echo. In Cath, we usually take peak-to-peak gradient. Can I put the picture, please? Yeah, now you can see here, the peak-to-peak gradient is used in Cath. Why? Because ideally, it is two catheters placed and simultaneously recorded, and it's the gradient at the peak. But if you see very carefully, I'm giving you the answer. The peak of the ventricular trace and the peak of the arterial trace do not happen at the same time. But when you take an echo gradient, you are slicing at this point. It is an instantaneous gradient. So if you take the peak-to-peak gradient on echo, you will get peak gradient will be false and it will not be correct. So we have to use and it is clinically correlated with the mean gradient. So the mean gradient on echo correlates with the peak-to-peak gradient on Cath. Today, actually, the things have gone one step forward, and modern Cath lab machines can even take the mean gradient automatically, and that is supposed to be more reliable than even the peak-to-peak gradient. So now oximetry. Now, why is oximetry done? Why is oximetry done? Anyone knows why oximetry is done?
Sir, to see the step up or step down at various chambers.
Okay. Now the next question is, how is 100% oxygen given in the Cath lab? How do you give 100% oxygen? See, for vasodilator tracing, we all read, no? 100% oxygen given. For pulmonary vasodilator, how do you give 100% oxygen? How do you give, if I want to give 100% oxygen, which mask do you have to use?
NRBM.
You have to have a close fitting mask so that there is a close fitting mask. Now, what is a pullback? See, what we do is we push the catheter to the distalmost point and then we progressively take the readings. There is an exercise for this. Now, what is a significant step up? Does anyone know what is meant by a significant step up?
Change of saturation of more than 15%.
15%, no. Now, I will tell you that before you go to this. Now, we don't take one single number and call it as a significant step up. Now, I will ask you a question. Cock crowed, sun rose. Tomorrow, cock crows. Again, sun rose. Third day, cock crowed. What is the chance of the sun rising? Higher or lower? Higher, no? Sir is ultimately. So, repeatedly, if I get some change, it is likely to be true. That is called Bayes theorem. Okay, all of you have read it in statistics, but I'm trying to put it in a very simple way. So if I say that the step up is 5%.
Other way of saying is change, however small, if seen repeatedly is
significant. True. We are trying to find the truth. The truth is that is there an ASD? The truth means ASD means there must be a step up. If I repeatedly keep getting a step up multiple times, I am likely to be true. Okay, the chance of me, the odds of me being true is high. So we don't have, so now do you know, that's why we say that we do repeated runs. First run, second run, third run. Now I will tell you, if I get up a jump, let us say in some place I get 5% step up. Again I get a 5% step up. Again I get a 5% step up. Is it likely to be true that there is a step up? Okay. Now, what are all the blood sources to the RA?
SVC, IVC, and coronary sinus.
What is the saturation in the SVC, IVC, and RA? Which is got the lowest saturation?
Coronary sinus.
Coronary sinus. Coronary sinus. Then why is the IVC saturation lesser than the SVC saturation? She said, anyone knows?
Brain uses.
I agree that their brains are not, but in your, I don't know. I'm making fun of them, sir. Not being used. So what should be there? If the brain is, your brain is not functioning, so what should be the saturation? This is a quiz question. I have put two SVC cannula, IVC cannula with both having the same color and asked what is the situation. In deep hypothermia, when you go to deep hypothermia, because the brain is not using, like you, if I take your thing, that will not be their case. But actually, why is the IVC saturation higher?
massive amount of blood coming from kidney.
Kidney, 20% of the cardiac output is coming from the kidneys. The function of the kidney is not primarily oxygenation of the kidney, but for GFR. Similarly, the gut also primarily for absorption, not for liver. They are primarily not doing this. Therefore, so all these things are coming. So normally there is a thing called a Fram's formula. You have to leave it 3S. One, I see all that formula you have to take. So, and then what is the value of the pulmonary vein sample? If not, in you and me, if I take a sample from the pulmonary vein, how much is it?
98.
Around 100 to 98. And then when it comes to the LA, ideally
should be 98. But
it will be a 2 or 3 step down because of the Thebesian vein return and this thing. So now I will ask you this thing. I'm going to start the cath, and the saturation is 50. The sample, venous sample is drawn, and the saturation is 57%.
What will be the arterial saturation?
Ask what is the arterial saturation next. The arterial saturation is 99.
No, I'm asking you. Asking them.
Okay, I give them this. Arterial saturation, pulse oximeter is showing 99%, and the cath venous sample is showing 57. I take a sample from the RA or somewhere like that, anywhere, and it shows 57. This is something for you in the ICU also.
So it could be severe sepsis.
Why sepsis? Why sepsis? You take a why sepsis?
Increased utilization of the oxygen by the tissues. That is why we have.
So apart from sepsis,
fever.
Far more common.
Fever.
Okay, far more common.
In ICU.
In ICU.
Patient brought 2 hours back, half an hour back.
And I have a big notice on my board. In my ICU, I have a big notice on my board. No patient should have a venous PO2 less than 27. If the patient has a venous PO2 of less than 27, a consultant will be immediately informed. Isn't it there, Manya, all of you, gang of 4? They don't know what gang of 4 is. Historically, what is it happening? Low cardiac output. If it's below 65% saturation or the venous PO2, absolute venous PO2 is less than 27, you are facing low cardiac output. So now, please read about omega and what is oxygen extraction ratio. There's no time. But now I'm going to give you a quick exercise. Pulmonary vein saturation, 90%. Put that thing, no?
Cause, quickly.
Quick. Pulmonary, we don't have time. Pulmonary vein saturation, 90%. You said it should be 100%, right? Now, pulmonary vein saturation, 90%.
So, primary lung pathology could be there.
Primary lung pathology or second? I'm having blood from the
pulmonary.
AV malformation, correct. Okay. All intracardiac chambers, 88%. All intracardiac chamber saturation, 88%. All intracardiac chamber saturation.
TAPVC.
TAPVC. What type of TAPVC?
Supracardiac.
TAPVC. Pulmonary artery saturation, 92. Aortic saturation, 84. They don't be apologetic.
Transposition of great arteries.
We have already done this. Patient waiting on table for cath lab pulse ox.
So marks are given.
SVC saturation 90%. Like your brains.
DHCA probably.
DHCA I have already told you, but we are in the cath lab or in the cath lab or in the
PAPVC.
Where?
PVC.
To the SVC. Okay. Now this is we'll do this quick exercise. Come, one of you come. See, now this is a little tricky that I have given. Go
on reading. You will come to know. Go on reading.
RA saturation.
Don't remove it. Timer over. This one thing we'll do. Yeah. Now tell me. No, this is not just a step up. Come.
RA 85 saturation.
Read it.
Full diagnosis.
Conclusion.
No jump in oximetry on
On
right side.
yep.
But saturation of 85 on the venous side is high.
High.
65, 75, SBC, IBC. RA became 85, 85, 85.
So
Left,
jump
right,
is in
center.
RA,
Jump in RA.
which is carried forward. This word you have to use, which is carried,
Carried
forward.
forward.
So it's
Huh?
not accidental. Same thing is carried forward.
And
Just
then,
now you get a knowledge which you carry forward. It's a good thing.
then see the pressure. What did we say? Atrial pressure, I put A, B, M as what? A wave, B wave, RA and
Equal.
LA are equal.
Equal.
What does it mean?
It is an ASD or
It is an ASD. It's corroborating the step up. You should be able to calculate the step up. Then next, now see very carefully. What is the LV pressure? 110 by
110 by 6.
6. There is atrial, and then what is the mean pressure there in the atrium?
Pressure is 9.
So what is the gradient across the mitral valve?
3.
3. Now what do you think about that?
So mitral.
Huh?
In the presence of ASD, even if you get 1
Single
millimeter
millimeter
gradient, it is significant.
What is the diagnosis?
Mitral stenosis.
So ASD plus mitral
ASD plus mitral stenosis.
Please come back.
Look at that.
with pulmonary hypertension.
And with PH. Huh?
RV
And
9.
is there no RV dysfunction? RV EDP is how much?
9.
9. Okay, there is mild RV dysfunction. Now angiography, unfortunately, we don't have time, but please remember, follow the course of the contrast.
Don't know Luttenbach?
You don't know.
You don't know Luttenbach?
No, I don't.
When are you appearing?
Sir, I'm in second year, right?
Okay.
So Luttenbach not.
Not yet studied.
Okay,
No,
not yet
it's a
studied.
MBBS
That
level.
means
Huh?
you have studied. Very good.
I'm just going to end this. How to read, follow. See, they came late. They came late. I'm on time. How to read, follow the course of contrast. First, identify the view. Today, don't use too much of brains because we are not using the Tagore now, but you can. It will be written there on the digital thing. So just read it. But otherwise, you should be able to see. See where is the spine. If it is on the left, then whether it is left or right, which will give you a clue whether it's a LA or RAO like that. Okay. Classical views can be explanatory. Multiple views. Why are they taken? In any angio, why multiple views are taken? Like this, is because if I see like this, it looks broad. But if I see like this, this is called as foreshortening, to avoid foreshortening. And if there is an obstruction, if I see it this way, it will look less. If I look at it like this, it will look more. So you don't want to have foreshortening, and so you want to have this thing. So you should know about determining the stenosis. What is the type of distal flow? Whenever you have a stenosis, what is the flow distally? And you should know how to grade regurgitation. That is called a Seller's grading. Please remember all of these things. These are the questions which I'm just going to give. There's no time. Why is LAD? Why is LAD? Because of find out the reasons. Why LAD is LAD? Why is OM? How do you recognize left main? Which view? What is dominance and its implication? Where is SA nodal artery? AV nodal artery may be asked. And read lesions according to the flow. So say that the blood is, this is the catheter. Don't forget, this is the catheter, and this is how the blood is flowing from, let us say, from A to B to C to D. You will never miss anything. I'm not going to do. And this is one last thing. Can you tell me what this is? This is something in the ICU. I always show this to students, Jaideva students, not to answer. What is wrong in this trace? Many people, this is a overt trace which I've shown hundreds of times. What is this trace? What is this trace? This is a ICU monitor trace. Yes, anyone? Why did you say tamponade? No, it is actually not tamponade. Tamponade would have, if you see there, it's a prominent Y descent. A tamponade will have a prominent X descent. This is a patient with RV dysfunction. Diastolic dysfunction of the RV. What will be your treatment for such a case? You'll have to increase the inotrope. You preferably use an inodilator like Milrinone or something like that. What is this? In the ICU. I told you, no, dicrotic notch and this thing. But now can you see something else? Not a dicrotic notch, but there is some other notch. Huh? No, I told you, Jaydeva student, because I've told it hundreds of times. This is the anacrotic shoulder. You have a aortic stenosis operated and you're still having an anacrotic shoulder. It means there is left ventricular dysfunction. This patient will collapse shortly. You have to reduce afterload. Even though the aortic stenosis has been relieved, the SVR is high in this patient. This very important one. This. Okay, Jai, what type of alternance is this? It is mechanical alternance, not just electrical alternance. There is 1:1 correspond. This patient is going to die soon if you don't act. It indicates there is significant LV dysfunction. So what are you going to do? Reduce the afterload, improve inotropy. So I always understand hemodynamics. There's a lot in the just even you can see, I've just given 3 traces. If you bother to see the traces in the ICU, you are running a cath lab there. Thank you. Yes.
Please show the anacrotic shoulder.
Yeah. Okay, how do I put this on?
You can go and touch actually.
Yeah. Am I that tall? Somebody tall, come no, boy. No, he is not taller than me. Come. We can't say.
Basketball.
No. There. Ascending limb. And the ascending limb, you can see that little camel hair, no? Okay, that's your
By the time the next speaker comes up, quiz, very severe tetrad, very severe cardiac cath done. What will be the LA saturation? Very severe. Blue, grade 4 clubbing.
Grade 4 clubbing.
Grade 4 sign cannot walk. Can walk only 3 steps and then squats. LA saturation. LA saturation will be 99%. Thank you. You have understood the physiology of tetralogy. The lungs are normal. So let other things, because he rightly said, no, the primary lung disease, only it will be less. Next
Thank
one
you,
is
sir.
ready?
To give us an overview on clinical trials, we now have Dr. Pradeep Narayan, Associate Editor of IJTCVS and Senior Consultant at Rabindranath Tagore Institute of Cardiovascular Sciences, Kolkata. He'll be joining us online.
Yeah, hi, just checking if I'm audible. Hello. Can anybody confirm if I'm audible? Sorry, I'm just checking if I'm audible. Can somebody confirm that? Hello. Look, somebody needs to confirm that I'm audible.
Hello. Pradeep, are you able to hear us?
Yeah, I can
Hello?
hear you. I just want to check if you can hear
Talking,
me.
but it is muted, Pradeep. Can you hear me? Can you put the Dr. Pradeep on?
Can you hear me? Hello.
Black magic. Please turn on the camera. And Pradeep, this thing is muted. Your mic is muted. Can you talk now?
Can you hear me?
No, again muted. And why are we getting two Pradeeps?
That is because I'm trying to.
Can you talk? No, it is. But why are we getting two Pradeeps? One is recorded. Huh?
Can somebody share my screen?
The trials now, one is as a comparison.
Share the screen. You will share from there. No?
These being trials, one is controlled.
Yeah, we can see the screen.
But can you hear?
We can hear you now.
Is it clear or is it echo?
Yeah, it is echoing because I think a second one is on.
Okay, what about now?
Better.
Okay. Thank you. Sorry for this mess up. So the idea is that in the next few minutes, I'm going to talk about clinical trials. And that is, if I can now move the slide. So aim of this talk is not to give you an overview of all the trials that ever happened in cardiac surgery, throughout, but just to give you an idea about some of the important trials and some of the questions that you might get asked in the exam, especially those where you don't know much about. So, for example, if you know everything about all the trials, then this talk is not very useful. But otherwise, because we don't really talk about trials too much, the best thing to do is before the exam, you identify the important trials, you read all the abstracts, and you try and remember the key message, the conclusion from the abstract, and try to think about them in the PICO format. Those of you who are not familiar with the PICO format, PICO stands for patients, intervention, comparator, and outcome. And I can tell you it's very simple. And if you follow this format, almost every trial you can write a short note on if you know the outcome. So patients, there'll always be patients with coronary artery disease. They might be diabetics or they might have left mainstem disease. If it's valve, it might be low risk or high risk. Intervention, almost always it will be randomized control trial. It will be multicentric. And if you can remember, see if it is an inferiority trial or a trial of equivalence or superiority. The other thing to tell you is that almost all the trials are trials of inferiority. So if you don't remember what to write, you can always write that it's an inferiority trial. Comparator will always be either beta versus CETA, CABG versus PCI, OPCA versus on-pump, or TAVR versus SAVR. And the outcome is the only thing that you have to remember. And I'll show you one example or few examples where how you can convert and just not even the abstract, just the outcome or the conclusion of the abstract into a short note. So this is the art trial, and this is the conclusion. Now I've highlighted some of the important words that you can use to write a short note. So let's see how we can do that. So using the PICO format, who were these patients in our trial? Patients were undergoing CABG, and the idea was to compare beta with CETA. What was the intervention? See, the black thing comes automatically. This is almost true for all the trials. So it was a randomized control trial. It was multicentric. And the primary outcome you have to remember is a mortality at 10 years. If you can remember the secondary outcome, it's fine. The comparator, simple, beta versus CETA. And the conclusion was there was no difference in survival at 10 years. And there was a survival advantage in the multiple arterial grafting group. So if you remember the conclusion very clearly, you can easily prepare a short note using different headings that will look, that will cover almost one page of your answer script and will hopefully get you enough marks to pass the exam. If you obviously know everything about art trial, then you don't need this technique, but otherwise you can use this. So some of the slides will have this question mark there, and that means that this question has either actually come in the exam or it's very likely to be asked. So art trial has been asked, current evidence for using beta has been asked, compass trial has not been asked, but I'll just tell you very briefly about it. So this was a study that compared rivaroxaban with aspirin in combination versus rivaroxaban and aspirin alone, and a sub-study was carried out of only patients who had CABG done. And what it found was that the patency rate of Rita was the worst compared to the other three conduits. So again, if you want to convert it into a short note, this is what it looks like. What was the COMPASS trial? Who were the patients undergoing CABG? What did we look for graft patency? See, RCT multicentric comes automatically. Primary outcome was graft occlusion. Comparator Lima versus Rima versus radial versus SVG. And this is what you have to remember. You have to remember the patency rates at 1 year. And your COMPASS trial is also done. If you have to answer a question on current evidence for using beta, we have already covered the ART trial and the COMPASS sub-study, so you can write about them. But I think you have to sort of add few more things. Like you have to add this systematic review by Godino that showed that beta was associated with a survival advantage, and there was a volume outcome relationship. Similarly, this systemic meta-analysis carried out among diabetics showed that beta was associated with survival advantage in the first 10 years, but not so between 10 to 20 years. And you have to remember this paper, which was published last year. This is a paper that has been quoted, innumerable times already. And it basically, again, using the PICO format, it shows that isolated CABG, patients who needed more than 2 grafts were included in the study. More than 1 million patients were included. It was not a randomized trial. It was a multicentric observational study. And it compared multi-arterial with Lima plus vein. And it showed that multi-arterial grafting was better than Lima plus vein at 10-year survival. And you had to do a minimum of 10 cases to see this advantage. Right. So I'll take you back to the ART trial. And in the purple at the bottom, you see there is an intention to treat analysis mentioned. Now, this was also asked in the exam as a short note. What is intention to treat? Some of you may know, but I just want to clarify this in a in a simple way. And for that, let's assume that we are doing a study where there are 12 patients who are undergoing either beta grafting or zeta grafting. Our sample size is 12. 6 patients need to be in each group. So this is what it should look like. But while harvesting the RETA, 2 of the right internal thoracic arteries got damaged. So now you're left with this situation that 2 patients in the beta group actually only had a single mammary. So how do we handle this? One option is we move these 2 patients to the other side. So we have 4 betas and 8 zetas in the 2 groups. This is your as treated group. The other option is you pretend that the zeta patients who were randomized to be beta actually received beta. So you just assume that. Once randomized, always randomized. This is your intention to treat group. So this is the difference between intention to treat and as treated. So if you have to write a short note, you can say several things. The intention to treat is a better way of analyzing data, and it is based on the assigned treatment group. The chance of bias is less, and it reflects actual clinical practice. So coming to radial artery versus RETA, this is another important trial, the RAPCO trial. And this compared, there were 2 arms in the RAPCO trial. You can see under the comparators that radial artery was compared with free RETA and radial artery was compared with saphenous vein grafts. What did it show? It showed that radial artery was significantly better than RETA. And with the veins, it was better, but there was no significant difference. You have to also remember that even though it was a RCT, this was one of those very few studies which was a single center study. It was not a multicentric study. Now, trials of TAVR versus SAVR, these are gaining a lot of traction, and a lot of questions get asked in the exam. And as a partner trial has been asked in the exam, long-term outcomes of TAVR has been asked in the exam. So I'll very briefly touch upon them. So there are 3 partner trials, and there is no rocket science to it. Partner 1 was in high risk and inoperable patients. Partner 2 was intermediate risk patients, and partner 3 was in low risk. It's very easy to remember. And you can see in partner 1, there are 2 terms, high risk as well as inoperable. So partner 1 is divided into 1A, that is high risk, and 1B, that is inoperable. And partner 1B was compared with medical management, not with surgery. 1B was inoperable for surgery, so you cannot compare it with surgery. And it was found that in patients who are inoperable, TAVR should be the new standard of care. What about the other partner trials? All of them showed that TAVR was non-inferior to SAVR, except partner 3, where the TAVR was found to be superior to SAVR. Now, you have to, I don't want to critically analyze all the trials, but here I just want to mention that why did this happen? And most of you would have done your thesis by now, and you must have done at least a sample size calculation. The sample size depends on the event rate. So if you want to show a difference, the more number of events you have, the easier it is to show a difference. So in partner 1A, the primary outcome was only death. So they were not happy, so they improved it to death or disabling stroke in partner 2. And even then, they found that TAVR was non-inferior to SAVR, so they increased it to death, stroke, or rehospitalization. And then they found that TAVR was superior to SAVR. TAVR versus SAVR in low risk. This is the in thing right now. And these are the 6 studies which have looked at that. And apart from the SUR-TAVI, which had 3 different cohorts, all these studies showed that TAVR was non-inferior to SAVR. In the SUR-TAVI, which was a post hoc analysis, and the partner 3, as you remember, TAVR was shown to be superior to SAVR. Interestingly, you also have to remember that in Notion 2 trial, bicuspid valves, SAVR was supposed to be superior to TAVR. So that's a lot of information, but I think there is no easier way to give it. And also I want to highlight that the definition of low risk is in these trials is very questionable. Partner 3, it was STS prom less than 4, in Evolute less than 3, in Dedicate less than 2. And in the Notion trials, they did not take STS prom at all. They took age cutoff. So that is something that you can talk about if you are asked in the exam. Now, trials for CABG versus PCI in different subgroups. So let's see what it looks like in diabetics. And this question has come, a short note on freedom trial has also come in the exam, and evidence for CABG in diabetics as well. So these are the 6 randomized controlled trials that have been carried out comparing CABG and PCI and diabetics. The top 3 one in yellow were designed to look at the difference, and the bottom 3 were subgroup analysis of trials carried out for other reasons. What did they show? All of them showed that CABG was superior, except the cardia trial, where PCI was found to be non-inferior to CABG. But all others said that CABG was superior. So bulk of the evidence is in favor of CABG. So if you were to write a short note on the freedom trial, or for that matter, any of these trials, all you have to do is to follow the PICO format. You know, diabetics, compare PCI with CABG, multicentric, prospective, randomized, and all except cardia, CABG was superior. That is all you have to remember. What is the evidence for off-pump surgery? Again, there are a lot of different studies which have been carried out, but I have only given you one which have assessed angiographic patency. So there are 10 studies which have compared angiographic patency, and all of them are randomized controlled trials. The reason some of them are mentioned in green is for you to remember easily. One in green showed that on-pump was better, and the rest of them showed that there was no difference in patency between off-pump and on-pump. So that's the evidence for off-pump grafting. Now, what about left mainstem disease? So this question has come a number of different ways. Excel has been asked, Noble has been asked, evidence for CABG in left mainstem also disease has been asked. These are the only 6 randomized controlled trials that have been carried out. Very easy to remember. Lehman's used bare metal stents. These 3 use the first generation drug-eluting stents, and only the Excel and the Noble use the second generation drug-eluting stents. What did they show? So apart from the Boudriot trial and the Noble trial, all of them showed that there was no difference. Boudriot and Noble showed that PCI was inferior to CABG. Just a bit more about the Excel and the Noble, because they have been asked as short notes. But if they do ask, this is how we have to write. Again, follow the PICO format. Patient's left main stenosis was more than 70% in Excel and more than 50% in Noble. Same format, randomized, multicentric, non-inferiority trials. See, both of them were non-inferiority trials. Comparator, one used everolimus and umirolimus was used in Noble. An outcome, no difference in Excel, and PCI was inferior to CABG in left main. Ischemia trial. So I'm not going to talk about ischemia trial because it has been talked a lot, but I'm going to just give you an overview as to how to handle this if it comes in the exam. So there are actually 3 trials which have been carried out in stable ischemic heart disease. And these 3 trials are the ischemia. What did ischemia do? It compared optimal medical therapy with PCI and CABG. The second one is the courage trial. What did it show? It compared optimal medical therapy with PCI alone. And finally, Orbita, which did the same thing, it compared PCI with placebo. What did it show? The ischemia trial showed that there was no difference between optimal medical therapy as compared to PCI or CABG in stable ischemic heart disease. Here, the only thing you remember is that most of the patients had PCI and not CABG. CABG was carried out in less than 11% of the cases. What did the courage trial show? It showed that there was no difference between optimal medical therapy and PCI in ischemic heart disease, stable ischemic heart disease. And Orbita further showed that there was no difference between PCI and placebo in stable ischemic heart disease. So this is a very easy way to remember these 3. Now, we talk about FFR also, and there is a lot of talk about FFR. Again, it's very easy to remember. There are 3 trials, FAME1, FAME2, and FAME3. What did FAME1 do? FAME1 compared angiography without FFR with angiography coupled with FFR. So it was only a comparison of angiography, with or without FFR. FAME2 compared optimal medical therapy with FFR-guided PCI. And once you compare FFR-guided PCI, it is obvious it will compare CABG with FFR-guided PCI. So that is what FAME3 did. What did this study show? So FAME1 showed that FFR reduced unnecessary stent insertion, meaning when FFR was not carried out, lot of unnecessary stents were put in during angiography. Lot of unnecessary hemodynamically insignificant lesions were stented. What did FAME2 show? That PCI guided by FFR was better than optimal medical therapy at 5 years. And what did FAME3 show? That PCI was not found to be non-inferior. It is a complicated term, but this is exactly how we have to remember. The not found to be non-inferior. It does not mean that it is inferior. These are different statistical terms. I'm not going to go into that, but please remember that it was not found to be non-inferior. It was a non-inferiority trial. I'm coming to the end of my talk. No-touch vein harvesting. So number of studies have been carried out. All of them showed that no-touch technique was better, except the superior saphenous vein graft study that showed that there was no difference. So we are awaiting the result of the sweet graft study, and this is still not been published. And just to end this talk by telling you that in the Indian Journal of Thoracic and Cardiovascular Surgery, every issue we try to publish a critical appraisal of trials. These are some of the examples. If you have been following it, or if you can go through them, you'll find that almost every single trial that can come in the exam has already been analyzed in detail if you have the time to read. Thank you very much for listening.
Can I ask question?
Yes, sir, of course.
Sir, this is Tendolkar.
Yes, sir.
I want to know what is primary outcome and what is secondary outcome. Who decides that?
Very good question, sir, especially for the students. So primary outcome is decided by the investigator at the beginning of the trial. It cannot be changed midway. Based on the primary outcome, the sample size is calculated. So if the primary outcome is death, we have to calculate how many patients we need to include in the trial to see a difference in death. For example, if we compare off-pump and on-pump, the mortality difference is hardly existent. So it might be 1% versus 1.2%. And we'll need about 10,000 patients. And if you add death and stroke to it, then the event rate moves from 4 to 5%. So now you'll need about 5,000 patients. If you add rehospitalization to it, the event rate will become 20% versus 35%. And now you'll suddenly need only 500 patients. So primary outcome is decided by the investigators at the outset of the trial. It is based on that is a sample size is calculated.
And suppose in a one trial, primary outcome is statistically significant, but secondary outcomes are not. So then we individually conclude like that, or it's a general conclusion which is drawn, saying that surgical wall replacement is superior to TAVR is superior to SAVR. Based on all outcomes should be statistically significant or not necessarily.
Sir, that's also a very, very important question. But I think rather than primary and secondary outcome, I think what you mean is composite outcome. So for example, the last example that I gave in partner 3, death, stroke, and rehospitalization. So in fact, sir, I'll give you a concrete example. Excel trial showed that the composite outcome of death, stroke, and myocardial infarction was similar between PCI and CABG. So the conclusion was that PCI is not inferior to CABG. But when you look at it individually, what we found was the risk of death was higher with PCI. So the rule is you cannot just give the composite outcome. You have to also talk about the individual component, because otherwise, if you are counseling a patient, it might sound like both PCI and CABG are fine, but the chance of you dying with PCI is higher. So it's a basic rule in research that you cannot just talk about the composite outcome. You definitely have to talk about the individual component. And that was the biggest controversy in the Excel trial.
So composite outcome is primary outcome plus secondary outcome.
No, sir. You can decide the composite outcome as the primary outcome. So this is what I'm saying. The primary outcome can be single or composite.
Okay.
I think another point that we have to tell is that you can't keep data mining after the primary comparators and other things are done, established. You can't say, I'll do subgroup analysis. And if you take 20, you will always get something positive. That's another important. Data mining should be viewed with suspicion.
Dr. Prasanna sir, basically subgroup analysis is allowed.
Yeah.
But I'll just refine it a bit more. Say you have done a study between PCI and CABG, including all patients. Now you do a subgroup analysis on diabetics, and you show that there is no difference between PCI and CABG. You can do that analysis, but you cannot say that there is no difference. The reason you cannot say is you did not calculate your sample size on the secondary outcome.
Yeah.
Did not.
The other point I want to say is that when you're doing multiple subgroup analysis, the p-value that you set has to be at a higher level with there are statistical methods to do the correction. Because you did not take an adequate sample sizing in the initial, your initial this thing, every subgroup is going to be smaller. The criterion which you, if you want to say it is significant, you have to have a higher p-value or discriminatory value. And it is better that if you are doing a subgroup analysis, it is pre-specified in the original thing, rather than searching for something post hoc.
Yeah. So that all good trials, you are right, will do a pre-specified subgroup analysis. However, having said that, post hoc, meaning after the trial is finished, post hoc analysis is not uncommon, and it provides us with valuable data. All we have to remember is the study may not be powered to detect a difference. What do I mean by that? If you see a difference, you cannot ignore it.
Yeah.
If you see a difference in subgroup analysis, you cannot ignore it. But if you do not see a difference, you cannot say that there is no difference because the study was not powered for that subgroup analysis.
Or rather, we can say that if you find a subgroup analysis which is not pre-specified, it is exploratory. You can, it is something to do further research.
Hypothesis generating. Yeah,
Hypothesis,
absolutely.
Yeah.
So,
Do you have any questions? Students, do you have any questions? Online, are there any questions?
Thank you, sir.
okay, thank you very much.
Thank you.
Thank you.
Thank you, sir. Thank you. Thank you for the
Thank you.
question.
We now have Dr. Balram Airan, former professor and head of Department of CTVS, AIIMS, Delhi, to guide us through fundamentals of IABP. He'll be joining us online as well.
Afternoon, dear faculty and the dear students. My sincere thanks to Dr. Hiramat and the organizing committee for inviting me to give a talk. This is a very important topic, that is the intra-aortic balloon pump. And I have been assigned the duty to talk about the fundamentals of IABP. What is IABP? The full form is intra-aortic balloon pump. Because with the help of a balloon, we are pumping the blood to help the myocardium to recover. It is basically a short-term mechanical circulatory support system which can help the patients where the heart is failing or there is myocardial dysfunction. Most of the times it can be used up to 7 to 10 days without any problem, but patients mainly recover within that period. It works on the principles of counter pulsations, which I'll deal with later on. It consists of basically two parts. There's a catheter, which is double lumen balloon catheter made of polyurethane. Its inner lumen is thin, and it is meant to monitor the arterial pressure during the IABP function. And the outer catheter, outer lumen is for the gas inflation. There is a console. With the help of that, we operate the balloon and we monitor what is happening to the patient. Also, there is a gas cylinder which supplies the gas for the inflation of the balloon. Historically, it was first Cantrovis in 1952. Experimentally, he found that if we block the arterial pulse peripherally, there is augmentation of this coronary blood flow in the animals. And that gave him the idea that we can help the patients with the myocardial dysfunction with this mechanism. In 1958, Harkin, he removed the patient's, the animal blood during the systole and then rapidly infused it during the diastolic cycle, and he found that there was diastolic augmentation. It was Molopolis et al. In 1962 who for the first time produced the experimental prototype of the intra-aortic balloon pump. However, in 1968, for the first time, Cantrovic, he used the IABP clinically in 2 patients, and one of them was successfully weaned off and discharged. Let us talk about something technical details of the catheter. There are advances in bioengineering which has led to the increased usage of this catheter with improved safety as well as the efficacy. With this improvement, it is seen that in America, more than 40,000 IABP catheters are used annually. The catheter size, which was large previously, up to the 15 French diameter, has been reduced to 8 to 9.5 French, and volume of the catheter is now 25 to 50 ml after inflation. Also, we have smaller catheters available for the pediatric use. As far as the insertion of the catheter is concerned, now we have got the sheathless balloons available, which are pre-folded. That means that without the help of the sheath, we can insert these catheters into the arteries. Now, how about the insertion? Previously, it was the open technique. The technique used the Seldinger technique, and we had to expose the artery, then suture a graft onto it, then put the catheter inside. However, Bergman et al., they came with the percutaneous insertion of the catheter, because now the size of the catheter was reduced and the catheter are pre-folded. Usually, we take the femoral artery for the insertion of the catheter. However, in case there is any problem, we can use the subclavian artery, axillary artery, iliac artery or the brachial artery. Even we can insert the catheter by surgical means, and that we can go through the transthoracic approach or the translumbar approach. Most of the centers now use the helium gas for the inflation of the balloon. Why we use helium? Because it is low density gas. It rapidly inflates the catheter, and also in case the catheter is ruptured, it is absorbed into the blood. Data Scope company has suggested various sizes of the balloon as per the volume of the gas, and vis-a-vis the height of the patient, which is listed in the slide. A proper size catheter and the balloon needs to be used for the proper augmentation of the diastolic pressure. In principle, it is seen that as compared to the descending thoracic aorta, the size of the balloon after inflation should be 80 to 90% so that it can function properly. Position of the catheter is very important. Neither it should be too high or too low. If we place the catheter 2 to 2.5 centimeters distal to the left subclavian artery, it is functioning normally. And it can be either placed with the help of the measurement of the length of the catheter vis-a-vis the patient, or the transincipitral echocardiography can be helpful in case we are placing the catheter intraoperatively. Trigger mechanism. There has to be a trigger for the balloon for the inflation as well as deflation. Now, there are three mechanisms with which we can trigger the IABP balloon catheter. Most commonly used the electrocardiogram. And the inflation recommended is at the onset of the diastole that corresponds to the midpoint of the T wave. The deflation is at the onset of the systole, and that corresponds to the peak of the R wave. However, in case the EKG tracing is poor, or there is electrical interference, or if there are arrhythmias, then triggering the balloon with the help of the EKG becomes problematic. Second mode of trigger is arterial pressure wave. We can inflate the catheter at the time of the aortic valve closure. That corresponds to the diacrotic notch in the arterial trace on its descending limb. And deflation is at the opening of the aortic valve. That is just before the upstroke of the arterial wave. In case both these trigger mechanisms are not possible, especially in cases of the arrhythmias, or when the heart is not able to pump blood enough to have a decent arterial pressure wave, we can put them on the auto mode. The augmentation can be 1:1. 1:1 means for every beat, or 1:2, that is once in 2 beats, or 1:4, or 1:8, as per the need of the patient. In case the heart is recovering, we can slowly increase the ratio. Similarly, the percentage of the balloon which is to be inflated, whether it is 20%, 25%, 40%, 50%, or 100%, depends on the condition of the heart and the condition of the patient. Now, if you see this ECG, it shows 2 points. The left one is at the peak of the R wave. So that is the point where the balloon is to be deflated. And the second point on the right side, the second arrow shows the mid of the T wave. That is the point when the balloon needs inflation. If we see the arterial trace, then this is the arterial trace which you see when proper augmentation is there. So the left-hand arrow, that shows the arterial diastolic pressure before the augmentation. The second arrow shows the arterial pressure at the peak of its arterial pressure before augmentation. The third arrow shows the diacrotic notch where the balloon is to be inflated. The fourth arrow shows the peak of the augmented arterial trace after the augmentation. And the fifth arrow is the arterial diastolic pressure, which if you see, that is lower than the unaugmented arterial diastolic pressure. And if you see the right-hand side arrow, that is again the peak of the arterial trace after the augmentation, which is lower than the arterial systolic pressure before the augmentation. This is the ideal tracing of the arterial wave when the balloon is functioning properly. What are the principles of counterpulsation? Well, counterpulsation means that we are against the normal pulse of the patient. So we are inflating the balloon during diastole. That means when the heart is relaxing, that is the point where the balloon is being inflated. And we are deflating at the time when the heart is ejecting. So it decreases the afterload in systole because it is deflating. So it decreases the afterload of the heart, while it increases the diastolic pressure as well as the volume during inflation. So during diastole, the balloon inflates and displaces the blood volume proximally as well as distally. When it displaces the blood distally, it is taking away the systemic vascular resistance. Proximally, when it is inflated, that is increasing the volume as well as the blood into the aortic root. So that is helping in the coronary blood flow. And the aortic recoil that helps in this mechanism. So overall, there is an increase in the coronary blood flow. There is increase in the systemic perfusion and this oxygen supply. Thereby, the systemic organs, they work better. And there is decrease in the systemic vascular resistance. So DPTI, that is the diastolic pressure time index, which determines the oxygen supply to the tissues and the organs, that increases with the use of the IABP. While the TTI, that is the tension time index, that decreases. It determines the oxygen demand of the tissues and the various organs, that decreases. So overall, there is increase in the oxygen supply, decrease in the oxygen demand, thereby the myocardial function improves in these patients. So what are the systemic effects of the intra-aortic balloon pump? Mainly it is on the heart, and that is what is our aim. So as I said, it improves this coronary perfusion, it decreases the wall tension and increases the oxygen supply. The oxygen demand is less. So overall, there is improvement in the left ventricular function. It decreases the left ventricular end diastolic pressure. It decreases the diastolic volume. And overall, there is increased cardiac output. It leads to the unloading of the left ventricle. The left atrial volume as well as the left atrial pressure, that decreases. Retrogradely, the pulmonary artery pressure decreases. And there is decrease in the right ventricular afterload also. This helps in the improvement in the right ventricle function. So there is biventricular improvement in the biventricular function improvement in these patients. What about the renal? Usually these patients who are in congestive heart failure or low cardiac output, they have got the decreased renal function. However, with the help of the IABP, because there is improvement in the cardiac output, it leads to the improved renal blood flow, increased renal perfusion, thereby urinary output is increased. It helps in reducing the tissue edema, helps in the myocardial dysfunction in turn, and the renal improvement. However, there are side effects of the IABP in the form of the hematological effects. That is, there is a mechanical hemolysis. So it leads to the decreased hematocrit. It decreases the hemoglobin up to 5%. There is thrombocytopenia. What are the indications for the use of the IABP? It may be medical or it may be surgical indications. Medical indications may be acute or elective. Acute conditions are cardiogenic shock, which is the number one indication for the use of the IABP. Acute myocardial infarction leading to the severe myocardial dysfunction, or it may be post-MI acute MR or ventricular septal defect. It is seen that with the use of the IABP, intracardiac shunting that decreases, and there is decrease in the myocardial regurgitation. Other indications include the refractory unstable angina and refractory ventricular arrhythmias. Electively, we can use the IABP in patients who are high-risk patients undergoing coronary angiography and percutaneous coronary interventions. In surgery, the use of the IABP includes in the acute stages when we are unable to come off the cardiopulmonary bypass, or there is a refractory left ventricular failure, or there is persistent ventricular arrhythmias or the atrial arrhythmias leading to the unstable hemodynamics. Electively, we can use the IABP in high-risk cases. For example, critical left main coronary artery disease with a low left ventricular ejection fraction, or the patients who are in congestive heart failure, patients who have got dilated cardiomyopathy with the decreased left ventricular ejection fraction, or preoperative renal dysfunction, or patients who have got cerebrovascular disease. It may be also used in patients with the end-stage heart disease as a bridge to the recovery or bridge to transplantation. There are some contraindications for the use of the IABP. The absolute contraindications include presence of aortic regurgitation, because in diastole, then all of the blood goes into the left ventricle. It increases the left ventricular volume, thereby jeopardizing the left ventricular function. Aortic dissection or aneurysm. If we use the IABP, it may lead to catastrophic bleeding and patient may be at risk. Or the patients who had aortic stents or the major arterial reconstructive injury. Patients with severe peripheral vascular disease may be in contraindication for the use of the IABP, unless until we find an alternative place to place the IABP. Relative contraindications include uncontrolled sepsis, because it is a foreign body, it may lead to further infection. If the patient has got coagulative disorders, or the patients have got persistent tachyarrhythmias, because then the IABP will not work. In patients who have got chronic end-stage heart disease with no chances of recovery, it is a dilemma whether to use the IABP or not. What are the other complications of the IABP? Mainly, it is vascular. Vascular complications include the dissection if we are not able to puncture the artery properly, or if we are pushing the catheter forcefully, if you are not in the proper lumen of the artery. Limb ischemia, in case the catheter size is more than the size of the vessel, or if the patient has got vascular disease. Pulse compromise is commonly seen. The pulse volume as well as the pressure may come down. So we have to watch for the peripheral limb ischemia. There may be thromboembolism, which may be because of the atheromatous disease of the arteries, or because there is clots formed around the balloon, which may embolize. It may also lead to the compartmental syndrome. Problems with the balloon may be because of malposition. If you have not placed the balloon properly, it may lead to hemodynamic instability. That is, if it is not functioning properly, then hemodynamics may be disturbed. It may not have the desired effect. Renal, in case the balloon is placed above to the renal artery orifice, it may lead to renal dysfunction. Similarly, there may be cerebral consequences. Other problem with the balloon may be it may rupture. Thereby, the proper inflation, deflation will not be there, and the augmentation will not be there. There may be balloon entrapment. That means that it is stuck. The balloon is stuck. It cannot inflate or deflate properly. Other problem may be gas leakage. So there we have to be careful that in case the augmentation is not proper, then we should re-inflate the balloon with the help of the gas. Hematological problem may be, as I mentioned, hemolysis. It leads to low hemoglobin or the hematocrit, and there may be thrombocytopenia. So these we have to watch carefully, and in case it is required, we may have to replace the blood or the platelets. Infection is another problem because it is a foreign body. So we had to take care of it. Cardiac tamponade is a very rare problem with the IABP. Once we have placed the IABP, how do we manage these patients? There has to be continuous hemodynamic monitoring. We have to see that the balloon is functioning properly. We should see whether there is a relief of the symptoms to the patient or not, whether the myocardium is recovering or not, which will be shown with the help of the arterial trace, with the help of the urinary output, and improvement in the other organs' functions. We should watch for the arrhythmias, because if the arrhythmias occur, then we may have to change the trigger from arterial pulse wave or ECG to the auto mode. Balloon function, as I said, must be observed carefully. We should watch the arterial trace. We should see that what is the augmented pressure, where it is as per the expected norms or not. Look for the gas leakage in case the proper augmentation is not there. Look for the complications which I have mentioned above. Beginning of the IABP. Once the hemodynamics of the patient is stable and it remains stable for a good time period, we can think of beginning of the IABP. We have to gradually decrease the augmentation ratio as well as the volume of the inflation of the balloon. Gradually wean it off to the balloon flutter, so that we are not stopping the balloon completely. It is still having some movements. Arrange some blood, because there may be significant bleeding from the site of the puncture of the artery. There should be sufficient manpower for the compression at the site of the puncture. In case the mechanical compressor is not available, always keep one extra balloon catheter available in case the hemodynamics of the patient again deteriorates. Remember, never put off the balloon pulsation completely. It should be on the balloon flutter, and with that, we had to remove the catheter immediately once we stop the balloon. Now we have got some questions for the candidates, and I shall request the chairperson to kindly point out to the candidate who has to answer these questions. Thank you. Hello. Hello.
Can you put the questions on? While the slide comes on, one question for the students is, in what phase of the cardiac cycle does the balloon inflate and in what phase of the cardiac cycle does it deflate?
Prasanna, this is the question it is asked.
And it inflates in? And it deflates in? No, it inflates and deflates both in diastole. Please remember that. It is a misconception that the deflation is already done in diastole. The other question is, what is the assisted beat and what is the unassisted beat? If I put it on 1:3, for example, which is the assisted beat and which is the unassisted beat? There is I will just draw the diagram. You have a beat here, and then you have the and now which is the assisted beat, which is the unassisted beat? Is very common misconception. Of these three beats, there is beat 1, 2, and 3. How many of you think that one is the how many of you think this is the assisted beat? Raise your hand. Okay, and how many of you think this is the assisted beat? You think that is the assisted. How many of you think this is the assisted beat? This is the assisted beat. This is actually the unassisted beat. This is where it fired. But the effect on the heart is this will come down, and this is where the SVR is actually this thing. Please remember that this is not the one on which the firing occurs is actually not the one. The one after it is the thing. Sir's questions, please. Can you please put sir's questions?
The last slide, please.
The second last slide? Yeah.
So what is counterpulsation? Basic questions.
Can someone take the mic?
Prasanna, can you coordinate with this one?
Yes, sir. I'm asking, what is, there is a term counterpulsation and there is a thing called as copulsation. Now, sir is asking, what is counterpulsation? If there is a counterpulsation, there must be a copulsation. So what is counterpulsation? Counterpulsation. Yeah.
Can't hear anything.
Sir, which goes against the direction of the pulse. The compression which is given from periphery.
No. Then even if it fires on systole also, it would be, according to your definition, if it fires on systole also, it is against the direction of blood, no? See, when the heart is ejecting, the balloon is not inflated. So if it were to go in tandem, it would have been called copulsation. Here, when the heart is ejecting, the balloon is not firing. When the heart is not ejecting, the balloon is firing. Okay? It is counter pulsating, not copulsating. Yeah. That's like counterflow in the, yeah.
Okay, next question.
The next question, can you show me the what is the size? If you place a wrong size balloon, there are two sizes which are possible. One is it is too large a balloon or too small a balloon. What happens if you put too large a balloon? Too large a balloon, too long a balloon. One, you could jackhammer any atheroma, number one. Number two, you can occlude vessels. So for example, if you put too long a balloon in too short a patient, you can obstruct renal vessels. If you put it too high, what will happen in a CABG patient? If it's subclavian, they think the lima, actually that is a question that if put the IABP and the patient collapses. That is a question for you in the exam. If you put how do you determine sir, can I ask, how do you determine the position of the balloon?
Right.
The basis of X-ray.
On the basis
tip of the balloon should be placed distal to the subclavian.
It should be distal to the, how do you know that? One is that the pulse can be seen. Two,
X-ray.
X-ray, when the thing is not beating, if you take the thing, you will find the radiopaque marker at the tip. 3, on TE you can see. On 4, on Cath or lab also you can see. Fluoroscopy you can see. All those are. Next question.
No, if you use,
sorry,
if,
too
if
small
you
a
use
balloon.
small catheter, yeah.
Too small a balloon?
Counter pulsations won't be effective.
Yeah, it will not be effective. If you use a small balloon in this thing, you will not get effective.
Okay, next.
How do you know the balloon has ruptured? Yeah, students have to answer, not the examiners.
We can see the.
Pardon? Somebody was answering?
Yeah, if there is blood in the gas line?
See the blood in the gas.
One. Before that, will the balloon function normally?
Augmentation is not proper.
Okay, suppose augmentation is not proper and balloon is not ruptured. What may be the other problem?
If the sir is asking if the augmentation is not proper and the balloon has not ruptured, what are the possibilities?
There is a gas leakage, so inflate the balloon again and see. So in spite of the inflating the balloon again, if it is not functioning properly, mostly the balloon.
What are the possibilities? Sir is asking balloon is, it is not ruptured, but it is not inflating. What are the possibilities? Dissection.
Dissection, balloon entrapment. Okay.
Balloon entrapment. It is kinked.
Okay, next question.
Next question. Can you put the next question, please? Sir has asked, how do you adjust the inflation deflation points on ECG and why so? Sir has given the answer also. Put a diagram also.
Answer is there, but I hope they had concentrated on that.
No. I'm asking, I'm giving them the clue that sir has given the answer, put a diagram there. You should be able to 100% answer now. What is the answer? But Mike, please. Mike.
The inflation happens, starts at the mid of the T wave and it stops just before the R wave.
Why is it done that way?
It happens in the diastole.
It is to restrict itself on the diastole. Next question. Same on the arterial trace?
Arterial trace, slightly different question will be there. That why inflation at the diacrotic notch?
Why is the inflation at the diacrotic notch? It indicates that the aortic valve is closed.
Suppose you inflate it when the aortic valve is open.
What will happen if you put the timing before the aortic valve is closed before the dicrotic.
It will
notch.
cause AR.
Yeah, it will
Okay,
actually
and-
worsen.
And if you inflate a bit later on than the dicrotic notch, what will happen?
Later than the dicrotic notch.
In low cardiac output, usually you have a trace which comes like that with a narrow QRS column. I mean, narrow arterial trace. Where do you consider as the dicrotic notch? How do you identify dicrotic notch in low cardiac output?
We have drawn the diagram before. There was a diagram, no? I showed you that what happens to the dicrotic notch in a patient with the SVR, it goes up. And if you deflate, if you inflate too late, what will happen? Will the effectiveness of the IABP be there? No. Okay. Next question.
Okay, now, if you do not deflate the question, if you do not deflate the balloon, okay, at the start of the systole, what happens?
What will happen if you...
If you do not deflate the balloon before the start of the systole, what will happen?
What will happen? You're actually
increasing
the work of the heart, right?
That's right. So you have to be careful about the inflation deflation point. Okay, next question. How do you know your balloon is functioning properly?
Very important.
Augmented pressures are more than the
So
unassisted.
there are two things. There is a balloon assisted systolic, balloon assisted and diastolic pressure, balloon assisted augmentation pressure. What happens to the balloon assisted pressures? There are two pressures.
Sir, augmented pressures are high and diastolic pressures are low.
Yeah, it should be lower than the
unassisted beats.
That is why the assisted beat is the beat after the balloon fires.
Good. Next question.
Next question. What is balloon flutter?
What is balloon flutter? I mentioned in my talk that you should keep the balloon at the balloon flutter. Do not stop it completely. What does it mean? What is a flutter?
What happens if you stop the balloon totally? Do you ever keep the balloon uninflated? I mean, not uninflated. What is it? What should I use the term?
Deflated.
Deflated. Do you keep the balloon ever totally deflated and watch? What will happen? It will thrombose.
Thrombose.
So it has to be. It has to always be.
Flutter means just mild inflation deflation. Okay. So that the clots don't form on the balloon. All right. Next, please.
I have one question, additional question. If you are using a balloon on IABP, if you are using the balloon on CPB, what are the advantages? What are the dangers? Can you use a balloon on IABP, on CPB? Yes. What is the advantage of that?
Pulsatile circulation.
Yeah, you get pulsatile. Now, can you tell me a fatal complication that can occur while using the balloon on pump? On CPB.
Embolism if balloon ruptures.
Balloon rupture can occur anywhere, whether it is CPB or not, but a fatal complication. And I will tell you, you're doing a CABG, and I'll give you a specific answer. You're doing a CABG, and how can you kill your patient when having a balloon firing? And what is the method to prevent that complication? When all can you potentially kill a patient while doing a CABG with the patient on pump, CABG with the balloon firing? Okay, I'll ask you one question. Would you like to, first step, would you like to put, I want to do it on cross clamp. I put what is the danger at that time? What do you do normally whenever you put a patient to cross clamp? You put the flows down. Now the balloon is firing. So what should you do? Stop the machine when you're putting the, but another very fatal complication is what happens when if I were to put a side clamp and I punch and there is a minimal gap or this thing and the balloon is deflating at this time, what will happen? Air gets sucked in. So when you side clamp to do your proximals, you must be 100% sure that your clamp is in place. Don't put the clamp when the balloon is firing, put it off, check. opening and then only start the balloon. And preferably many of us will like to have the clamp not on at that stage. You may keep it for pulsatile flow. Whether that flow is beneficial or not is something a matter for debate, but please be aware, because you may be having a patient with a CABG who's in cardiogenic shock shifted from the cath lab. This is a reality. Then any other next question, please?
Next, please.
What is the effect of arrhythmias on now I'll ask you two questions. Atrial fibrillation and ventricular tachycardia. Both you have to answer. Ventricular ectopics. What is the ischemic ventricular ectopic is there and atrial fibrillation is there. Can you use the pump? What you have to use? What mode will you use it in?
So pressure mode, pressure trigger.
You can use it this thing, or you can go. There are arrhythmia modes. This was not possible in the older balloons because we now have a better shuttle gas and faster electronics and valves and other things. We can use them now in atrial fibrillation, but you have to use the AFib mode. What is the effect of IABP on ventricular ectopics? Ischemic ventricular ectopics?
Because of better cardiac perfusion, ectopics reduce down.
If they're these things, ischemic ectopics will decrease. And what do you do if there is a pacemaker? There is a pacemaker.
It will sense the trigger from the pacemaker.
There is a V-pace mode. You have to use the V-pace mode or dual pace mode. All those modes are there in modern day. They say why? Because it will start sensing this pacemaker spike and then make the triggering. If you don't know how to trigger, always remember that you can use the pressure mode if there is a problem with the ECG mode. But for that you need to have a valid and on full cardiopulmonary bypass with the cross clamp on, how will you get? I want the IABP to be put on. How will you do? There is no ECG, there is no pulse. How are you going to run the IABP? There is no ECG trigger. There is no arterial trace, right? On full cardiopulmonary bypass. How are you going to? I want to have pulsatile flow. Yes, you have to use the internal mode. Okay. The next.
Next, you can skip. Maybe we can go to the next one.
Next question.
You can skip this one.
When will you set the auto mode function as a trigger? You wanted internal mode or auto mode, sir?
Auto mode.
Auto mode.
When AF keeps on happening and we are not sure.
No, auto mode is with a valid, when you have good traces. Okay. Auto mode is an automatic mode. It selects which is the best thing and it does it. So you should have a valid trace. Internal mode is when you are not having a trigger.
And even if there is no cardiac activity, you can use the internal mode.
Internal, when there is no cardiac activity. Basically, whenever you are doing, for example, you are doing CPR and the balloon is there.
Okay. Next, last question.
If you detect limb perfusion compromise, what will you do? What?
Take out the balloon and put it on the contralateral side.
I don't want to take out the balloon. There is right femoral stenosis, some stenosis. Left side is IABP, and the patient is not venable. I can't remove today.
See, in my presentation, I forgot to tell you that these patients need hyperinization.
Yes.
Okay. So now you tell me with that background, what will you do to this patient who has got some limb compromise? Limb compromise, mind you. Okay.
Limb compromise, yes. If you want, you said that if there is this thing, just remove the balloon or anything else you'd like to do. Sir is giving you a hint. Heparin. No, not heparin flush. Now you have limb compromise. He's saying there's established limb compromise now.
Keep the ACT higher.
Established limb compromise.
In that case, you'll have to remove the balloon.
Take out the IABP and doing something else. You might have to do something else. You might have to do an embolectomy. What is medical embolectomy? Medical embolectomy.
Pharmacologically.
Yeah, give the thing. Medical embolectomy is when you have placed the IABP for a long period of time, even though you've heparinized and other things, there may be some thrombus on the, on what is it called? Not on the balloon, but on the shaft. So at that time, what do you do?
Give distal pressures to allow the proximal flow and any
Yeah, you
thrombus
allow
to
it
come
to
out.
flow, then?
And then you give proximal pressure and allow any distal flow to come out.
Okay. Then how do you do in compromised vessel? How do you do? What are the ways in which you can place a IABP in a compromised patient? Let us assume that the vessel is quite small, or I have peripheral vascular disease. What are the ways in which you can put IABP? Yeah, or you can show a graft to the vessel, number one. Number two, you can use alternate sites. Please remember that have you heard of ambulatory IVP? Ambulatory IABP is done by placing a graft to the axillary artery and then threading it through the axillary artery. For example, if patients are waiting for transplant and LVAD is not an option, you can put ambulatory IABP. It has been done. And then any other, I am doing a CABG in a patient with the aorta bifemoral disease, and I want to put a IABP. I am not doing aorta bifemoral grafting, and I have got a patient with aorta bifemoral disease, and I am doing a CABG on him, and I am not now need to put the IABP.
Transthoracic.
How do you put it? You can put it directly to the aorta. Yeah. Yes. And then there are other methods. Be aware that another thing is that people have even sutured a graft to the aorta and brought it out and to the lower part of the incision to ease removal. But most of us, if the patient is that sick, is also going to have the chest open, very likely. Okay. But these are all things which have been done, especially when mechanical assist is not available and things like that.
One more question for the students. We have been discussing that the IABP increases the blood supply to the left ventricle, but how does it reduce the demand of the ventricle? Can you explain that?
It decreases the afterload, sir.
How? So
how does it decrease the afterload?
At the time of ventricular ejection, it displaces the volume of the blood because it has emptied the segment of the aorta which previously it was inflated in.
So LV is ejecting into an empty aorta.
Empty aorta.
So how does it help the LV?
Decreases the afterload.
Actually, see, there is another
I want
thing.
to know.
Most of you are
exactly how.
See, it is not just that it creates a space. Please remember that one of the functions of the IABP, and that is why the balloon-assisted peak diastolic pressure has to be higher and the balloon-assisted end diastolic pressure is lower, is the tidal wave that is generated along the vessel goes to the goes down to the capillary bed, and the precapillary sphincters require energy to keep them open. That is why normally, if you don't, when you go on CPB, there is an immediate fall of the pressure, and then it slowly increases over time due to multiple reasons. And one of it is when you have a non-pulsatile flow, which is in the normal range, there is progressive precapillary sphincter in its default state goes into constriction. When the tidal wave goes in, energy is transmitted, that mechanical energy to potential energy, back to mechanical energy, transduction of energy occurs, which keeps the capillary pressures open. This was thought to be why pulsatile LVADs were there for so many years till Dr. Stephen Westby, very famous person, introduced the first pulseless VAD, where he showed that if you have a high enough flow, see now what we are doing in CPB, we are technically giving just above shock flows. We are just giving just above shock flows, but when you give a proper good flow, they demonstrated that after a period of time, the capillary sphincters go, because the energy transmission now is potential to potential energy. Understood? To mechanical energy. There's a slight difference. Yeah. So you are using low flow, relatively low flows here, but that is why you are in just above shock flows. Yeah, done. Manpreet is telling our time is over, sir.
Okay, thank you, Prasanna.
Thank you, sir.
Very much for assisting. Thank you very much.
Anything else you want to add, sir?
No, thanks very much. I think these questions I thought will be useful for the students from practical point of view. So that's why. Yeah.
Thank you.
Okay, thanks very much. Thank you.
Thank you, sir. Tea break for next 15 minutes. Then we'll restart with the ABG and VBG session. I now request Dr. Parimala Prasanna Simha ma'am, Professor of Cardiovascular Anesthesia at Sri Jayadeva Institute of Cardiovascular Sciences and Research, to guide us for interpretation and management of ABG and VBG. Over to you, ma'am.
Good morning. I thank Dr. Hiremat and IACTS for inviting me for this discussion. So we are looking at the ABG to know the oxygenation, ventilation parameters, acid-base balance, venous blood gases we do along with electrolytes and blood glucose. We need a rapid, accurate and immediate method. Here it
No, it's there. This is not yours. Huh? This one is not yours. It's yours.
So we have basically a pH electrode, a PCO2 electrode, and a PO2 electrode. Other parameters are calculated or derived. First, we'll discuss about oxygenation and ventilation. And in oxygenation, along with measured PO2, we get oxygen content, oxygen saturation, a alveolar arterial gradient and ratio also. So during cardiac arrest, initially there is hypoxia and PCO2 buildup, acidosis, and post-resuscitation we have problem if we give excess oxygen and because of respiratory alkalosis. With hypoxia in the neuronal tissue, there is increased lactate production. It causes contractile dysfunction in the myocardium and lung. Also, there is macrophage activation and inflammation. And during hyperoxia, there is increased free radical oxygen synthesis and related damage with coronary ischemia. And in pulmonary, hemorrhagic pulmonary edema can occur. So we have to avoid hypoxia, that is PO2 less than 60, hypercapnia more than 50 during arrest. And during resuscitation, we should avoid hypocapnia below 30 and hyperoxia, that is more than 300 mmHg of oxygen. Hyperoxia toxicity can cause hypoxic pulmonary, inhibits hypoxic pulmonary vasoconstriction, can lead to atelectasis, hemorrhagic pulmonary edema. So this is a case of post-operative patient now for with respiratory alkalosis. The pH is 7.47 and PCO2 is 21. This actually leads to development of compensatory metabolic acidosis. So you see that the base excess is -6. Commonly, the residents start giving sodium bicarbonate looking at base excess. But here the primary problem is hyperventilation, which is most common issue when we shift the patient to the ICU. So correct respiratory alkalosis, then the metabolic acidosis, which is compensatory, will be corrected on its own. The another case where we get respiratory alkalosis is a patient is extubated, then there is fever, breathlessness, productive cough, and room air saturation is 85%. Here the pH, if we do APG, is showing alkalosis with the PCO2 of 24 and PO2 is reduced. The explanation is pneumonia has led to low VQ areas and shunt, resulting in increased alveolar arterial oxygen difference. And this hypoxia leads to vasoconstriction response, and hyperventilation and respiratory alkalosis. So this is oxygen dissociation curve. For the same PO2 of 50, you can see that there can be a saturation of 85. And if the binding is loose of oxygen to hemoglobin, it can release the oxygen to tissues. It happens in lungs, in the tissues as well as with acidosis or CO2 retention. Whereas if the binding is tight, then the saturation will be high, 90%. For the same PO2, this is left shift, which occurs in the fetal hemoglobin and as well as in alkalosis. So what we see here is PO2 of 28 has a critical oxygen saturation of 50, below which the tissue oxygenation suffers. Normal range, you can see that is between 40 to 100, better, and the oxygen content is normally around 20. Another point you have to see is PF ratio. At room air, PF ratio is more than 400 because if PO2 is 100 and FiO2 is 0.21, so the calculation comes as 476, or PO2 is equal to FiO2 into the PF ratio. Why we need to know this is, in these two ABGs, one time the child is receiving 25% and PF ratio is 220. And we have increased FiO2 to 0.35 and the PF ratio is 268. Or if we have to calculate PO2 at room air for this patient, it will be 46 and 56. 56 is low, but still better than receiving 25% FiO2. So when we have a PO2 of 100 and saturation 97%, this value is different for FiO2 of 30, 50, and 100%. You can see that in the FiO2 of 30% situation, PF ratio is 300. And at room air, if the same patient, if we calculate, the saturation would be 93%. So 30%, giving 30% oxygen would be acceptable. Whereas in 50%, it comes down to 75%, and 100%, as you see in ARDS situation, saturation will be low. The question is, if we want to reduce FiO2, whether patient will tolerate this low PO2s or reducing your FiO2. You have put initially 60%, then you come down to 40%, or you want to extubate. That time you want to know whether the patient will tolerate reducing FiO2. You can make use of the PF ratio and see what is the predicted PO2 for that FiO2. Now, acid-base balance, we want to see the metabolic acidosis. So pH is low and lactate is high, bicarbonate is low, and base excess is -9. So here we make use of actual bicarbonate and standard bicarbonate. And this is another picture where you see that the lactate is high, but there is not much acidosis. And this is commonly seen with post-surgery patients who are receiving a higher dose of adrenaline. This causes increase in lactate, hyperlactatemia. It's a beta-mediated effect. It is not related to reduced tissue perfusion, and it does not have poor outlook of lactic acidosis associated with shock. Because if we want to extubate with ERAS protocols, earlier they would say lactate more than 4, you wait till the lactates come down. Lactate takes time to be eliminated from the body. So now recent guidelines will not stress on lactate levels for extubation or weaning the patient. You can go ahead if there is no tissue hypoperfusion. So why it happens is adrenaline with beta mediated effect drives glucose into the cell, which is converted to pyruvate, but mitochondria cannot handle so much of pyruvate, so it goes into anaerobic metabolism and lactate production. Similarly, in sepsis also, hyperlactatemia can occur because of the pyruvate dehydrogenase enzyme inhibition. We have to know about anion gap, which is the difference between major anion and cations. So this is to determine whether the base deficit is caused by addition of acid or loss of bicarbonate. Base deficit with elevated anion gap is usually addition of acid like ketoacidosis, and loss is because of loss of bicarbonate. So in this ABG, you can see that down there is anion gap of 23. Normal is less than 10 or 12. So this is high anion gap, lactic acidosis. You can note that the potassium is also increased in this patient and base excess is -19. So when there are mixed disorders, first we should check the PCO2 levels. If PCO2 is normal, then look at the anion gap. If that is normal and bicarb is normal, it's a normal ABG. And if anion gap is high, then we know the difference between the anion gap and the bicarbonate difference. That is 24 minus the actual bicarb. Then if both are, if the anion gap is, the ratio is less than 1, it is usually multiple non-anion gap as well as anion gap acidosis. Whereas if anion gap is higher, more than, the ratio is more than 2 compared to bicarbonate, then there is some metabolic alkalosis. So now correction of metabolic acidosis. So in the first ABG, you see that the pH is 7.43 is normal, and not much base excess or bicarbonate difference. Only lactate is high. This doesn't need correction, whereas the second ABG shows that pH is 6.9 with -26 base excess. So this second one requires correction. Treatment is with correcting the predisposing factor, volume infusion, and bicarbonate is given when pH is less than 7.4, PCO2 is also less than 30, and base excess is more than -2. A dose is 0.3 into body weight and give half of this. We have to know a few points about oxygen delivery, oxygen extraction ratio, and venous blood gas. So in the normal adult, when oxygen content is 20 ml per 100, that is around 1/5 of cardiac output is 1000 ml per minute. And consumption is 1/4 of that, 250 ml. But as the delivery decreases, initially the reserve will take care, but when it falls further, it becomes supply dependent. So this is an article from JTCVS in 2020. They have studied association between oxygen delivery and cardiac index with hyperlactatemia during cardiopulmonary bypass. So this goal-directed perfusion is also included in the IRAS protocols, so that we want to see that with goal-directed perfusion, the lactate doesn't increase during bypass. So they have studied in first group maintaining a delivery of oxygen at 280 ml per minute per square meter based on the oxygen extraction ratio, which is maintained at 25%. In group B, they have maintained flows at 2.4 liter per minute per square meter with saturation, venous saturation around 75%. And you can see that the significant less lactate increase with oxygen delivery method. So delivery of oxygen is calculated based on the formula 10 into the pump flow into the arterial content. And arterial content is some ABGs will give you directly, otherwise it is the formula which you can use. Oxygen extraction ratio is oxygen consumption by delivery, or it is CaO2 minus CVO2 by CaO2. In the second group, they have just managed with flows and SVO2, maintaining it at extraction ratio of 25%. So now critical delivery is, this is 330 ml per minute, because if it is below, then the extraction becomes supply dependent. So delivery is dependent on, based on the formula, cardiac output, and in a normal person, gas exchange and hemoglobin concentration. Oxygen extraction increases with increased metabolism and decreased with sedation and hypothermia. So you can see that the partial pressure of oxygen is 90 in the arterial, and venous it is 40. Similarly, the saturation is 75 in venous and more than 98 in the arterial. So we can surrogately use central venous oxygen, and normal is around 70 to 89%. And this is VPG change that occurs earlier in low cardiac output state, which is not reflected in the arterial saturations or pH. So here you see two ABGs, one is ABG, another VBG. ABG is showing normal PO2 and lactate is normal. Whereas in VBG, you can make out that saturation is 55, which is low. So a low saturation increasing CO2 acidosis in the VBG is early sign of low cardiac output. Can be used to treat arterial hypoxia, to estimate cardiac output, and in sepsis protocols and patients, it helps in weaning failure and also for shunt fraction calculation. Few points about respiratory acidosis. PCO2 is 47 here, and 3 different ABGs there. In the first ABG, you see that it is only respiratory acidosis. In the second ABG, there is combined respiratory and metabolic acidosis. And in the third, it is, in second, it is pure metabolic, and third, it's combined. And metabolic alkalosis, pH is more than 7.57 here. And the causes are multiple. Chloride responsive, it's because of volume depletion, or resistant because of potassium depletion. But common problem we see in ICU is excessive soda bicarb administration. You can see in this patient, the pH is 7.5 and bicarbonate is 42 and base excess is plus 24. This is due to excessive soda bicarb given, and because of that, PCO2 may be high transiently. And so we have to see that we don't give unnecessarily soda bicarb in ICUs. Sodium also starts increasing. So electrolytes, one important thing we are worried is high potassium. Here you can see there are 2 ABGs of same patient. The first is VBG showing a potassium of 10.3, and second one is showing potassium of, this is arterial, showing 8. So why high potassium occurs in the cardiac arrest situation? Because excessive hydrogen ions, which are present, the cell wants to maintain the electrochemical neutrality, so potassium is excreted into the extracellular space. Now, in low cardiac output situation in children, what happens to potassium balance? So oliguria with rising potassium, that is more than 5 milliclins in 4 hours, with other signs of low cardiac output, fall in the pedal skin temperature, rising esophageal temperature, And these are features of low cardiac output with hypotension and acidosis, which are late to manifest. So this child underwent TAPVC repair. Initially, potassium was 2.6 after shifting, and there was alkalosis. But within few hours, the potassium started rising with no other indication. The pressures were fine. And during CPAP, suddenly child arrested. The only initial indication was high potassium. So treatment is when the concentration goes beyond 6 and there are ECG changes. We have to give for correcting the ECG and arrhythmia, intravenous calcium. And other agents are insulin with glucose, beta agonists, and sodium bicarbonate. Use of sodium bicarbonate for potassium is not very useful. So we give bolus of 10 units of insulin with 50 ml of glucose or in combination with albuterol as nebulizer. Diuretics, cation exchange, resin as with sorbitol and dialysis are other measures. How we manage hypokalemia? When serum potassium is 3 to 3.7, you can add it to the maintenance fluid. If it is less than 3, then we give infusion of potassium chloride at a rate of 0.5 millicoulant per kg per hour. So one point about euglycemic diabetic ketoacidosis. It's a rare complication of diabetes when sugars are normal, but there is ketoacidosis. And this is because of now these days we are seeing patients using sodium glucose that SGLT2 inhibitors. And there is increased anion gap metabolic acidosis, ketosis, and glucose levels may be normal. It has significant risk of dehydration, delayed diagnosis and treatment, and adverse metabolic consequences. Fluid resuscitation with 1 to 1.5 liter per hour isotonic fluids. Insulin has to be maintained with glucose to prevent hypoglycemia. And sodium bicarbonate is not indicated even with severe acidemia. Thank you.
Ma'am, if base excess is high and PCO2 is also high, so how to go about in those patients?
So that's why first we always see the pH. If
pH
pH is alkaline, towards alkaline, the primary disorder is respiratory alkalosis.
Okay.
So PCO2 is high, you say?
Yes, and base excess is also high, bicarb is high. If base excess is +7.
So there is respiratory acidosis with metabolic alkalosis. So in this patient, if patient
in this case, why not consider the other way? Metabolic acidosis with compensatory respiratory alkalosis. Metabolic alkalosis. How to decide what is primary?
pH, sir. pH will tell. If pH is like I showed in the earlier, pH is.
Tells you alkalosis or acidosis. Which of the two is primary? Metabolic or respiratory?
Clinical correlation also.
Medical correlation.
Clinically.
Another thing, another question, all her
My
problem is solved.
not
Her
answered.
problem not solved. If you do blood gas immediately after giving soda bicarb, you will get falsely high pH and high PCO2. Because bicarb finally combines with acid and breaks up into CO2 and water. So if you do within few minutes, you will always find high PCO2.
No, my point is there's a persistent PCO2 high and base excess is also high.
So ventilator requires
Patient is extubated. Post that, this is the issue. Persistent.
Also seen with dopamine Lasix drip. So very common to see dopamine Lasix drip.
That we are giving.
is like sodium is high, give thiazide like metalazone. If bicarb is inappropriately high, give
Acetazolam.
acetazolam.
And ma'am, how to decide that at what base level, how much PCO2 will be high to expect that this is metabolic related PCO2 high?
There are formulas actually. What we do is if we see the pH, the last two digits like 7.34, the PCO2 should be around 34.
Okay.
So if there is discrepancy, and then there are formulas, exactly 0.8 into the PCO2 levels. So there are formulas to say that this is the expected PCO2. If it is low or high, then there is additional respiratory component.
I think another important thing that most people should see is the standard bicarb. Standard bicarb eliminates the respiratory component. If you remember that one thing, 90% of these confusion will be. If the standard bicarb,
we should stop looking at base excess. You should start with pH, then bicarb levels. Like that, I wish she had given one flow chart of how to go around. Unfortunately, we all first see how much base excess, -3, give immediately. So that all thinking should be stopped. pH, then standard bicarbonate levels, and then anion gap, and then other things to be.
So I have one EBG, sir, like 7.45 pH, 7.45 pH, PCO2 around 61, and PCO2
extubated patient.
extubated, yes, 61,
Compensatory.
and base excess is around 6 to 8. It's varying, and bicarb is 32. So whether X-ray is clear, so whether it is related to lung or it is the metabolic thing.
Mostly, if as discussed, if patient is on LAS6 infusion, it leads to chronically metabolic alkalosis, which is compensated by the respiratory.
That is clinically.
But 60 is high. We should rule out respiratory issues.
Another thing which I want to tell all PGs is there are dictum is if there are 2 consecutive AJJs with acidosis, think of the cause. It is not bicarb is not the issue. It is the cause. Now, another thing that is if you have hypoxia, the treatment is not oxygen. The treatment is the cause. Oxygen is a temporizing measure. I think I have told this 100 times. In fact, I like to remove oxygen and I want everyone to be tense. There is enough evidence to say that above 92%, giving oxygen even for an MI is detrimental. It increases infarct size. So oxygen is not good. That's why I always make a statement. Is the oxygen for you or the patient?
Relatives.
Other relatives. Above 92%, there is no benefit of oxygenation. It actually causes worse outcomes. So your treatment should be the cause. It may be atelectasis, pneumothorax, whatever.
Question to all, what is the definition of mixed venous saturation? So what is mixed vein?
It was discussed.
Same thing, Cath, you saw just.
Cath, we did it.
Cath, same, which is mixed venous saturation?
No. Array. Mix.
MPA. Ideally speaking, MPA. Patient on ECMO. Now, which is mixed venous saturation? Tricky. Understand? Particularly, what is that? Single catheter. Single catheter.
Avalon catheter.
Huh?
Avalon catheter.
Single catheter. So one same catheter gives volume and same catheter withdraws volume. So the big chance of recirculation. So you must be extremely careful while drawing blood for mixed venous saturation. All madam has told will go waste if you collect a wrongly placed venous blood sample. And you will say, wow, excellent PO2, excellent pH, etc. You are actually collecting from a wrong side. If you collect near renal vein, all your values are going to be excellent. So just remember, mixed venous saturation, exact definition from where you collect is very, very important.
That is why that
temperature
is SpVO2.
Temperature also is important. Incidentally, sir introduced this concept of VSAT long back. Somehow This much of knowledge we did not have. Sir told we started doing, and we used to consider 60% as a cutout limit those days. But it was very easy. Instead of doing all these things, same blood gas machine, just inject a venous sample and you get. That's why blood sample collected from skin, periphery, will
Not
be
a-
of no value because oxygen extraction of skin is very low. As against that, suppose your catheter is near coronary sinus, you will persistently get a very bad venous saturation. So that is the importance of
in fact,
collecting sample from the appropriate
actually, sir, even that coronary sinus is because both me and Parimala had done studies where we showed the effectiveness of cardioplegia by taking the effluent coronary sinus this thing. So it's very important that when you are open the RA and you're using cardioplegia, sir, what did he say? That time we had yesterday discussion that that if you have given proper cardioplegia, the coronary sinus effluent, which was black, becomes red, as equal to the this thing means you have met the metabolic requirements of the heart for that period of time. So remember, venous is, have you gone, who has come
What is the
out of the
next
movie?
program? We are
Yeah.
filling the gap. We are filling the gap. तुम बुलाना चालू करो ना, तब
That's
तक
why
हम
they
लोग
call it as
बात
SCV.
करते रहेंगे तो सब हो गया. Okay. Another homework I want to give you: post-operative hyperkalemia causes. Patient has undergone open heart surgery on bypass, baby preferably, and what are the causes of hyperkalemia? One thing, Parimala, your next slide should have effect of hypothermia on levels of potassium and normothermia on levels of potassium. That is very practical. Many anesthetists moment on bypass in hypothermic state, potassium is low, they start giving potassium. It's very common in KM. So because you are going immediately by that.
Sir, before we end, I want one photograph, sir. Bhattacharya sir, the lineage of 6-7 generations. Please come, sir. Before we start, 2 minutes, sir. Aja, Bhattacharya sir, please come.
Sir will require that. Sir demands that chair. No, sir demands that chair.
Sixth generation.
No, only generation. Six generation.
Bhattacharya student is Dr. Tagore student, me student, not that. Sixth generation. Oh, you mean? Yeah, that's why you are there. You are here. And Manpreet, Manpreet student actually come student of Manpreet student of Veeravan. Yeah, Manpreet. Manpreet come there. That boy is Kaushik student, so he can come in. He's photo bomb. So you got picture. Sir.
The bell-shaped curve था, 2 outliers and rest of them in bell-shaped. आप outlier थे, ये भी outlier था, not touching each other.
Thank you, sir. So next, now we move on to the case presentation session. The presenter for the next case presentation is Dr. Manya, Dr. Joseph, and Dr. Anoop from Jayadeva Institute of Higher Medical Sciences. The examiner for this session are Dr. Vinayak Shukla, sir, Dr. V.V. Bashi, sir, Dr. Adarsh Koppula, sir, and Dr. Anand Agarwal, sir. I request all the chairpersons to chair the session, please. So time duration is 1 hour, sir, for this case presentation. Valvular.
I want 4 e-books free and freely available. So how many you have got? Unfortunately, books don't get conducted to pain. They have to keep it under the pillow. So we are not developing a pen drive. Keep the pen drive under the pillow and the knowledge will be automatically conducted. Okay, but you have to pay for such very high top quality pen drive. Your pen drive has now to keep it under the pillow. The knowledge automatically gets.
It's called AI.
So it is called natural stupidity.
Okay, start here now. Who took the photograph? Please listen to us now. Somebody will start.
No, it is in the main. I also have one.
Can we start?
Yes, please.
We can't start if you're keeping on talking. Yeah, please start. Okay. So among the three of you, who is presenting the case and who is presenting investigations and who is presenting operative training?
I'm presenting the history. Manias.
We have finished with the history presentation and all yesterday. I think you must
Joseph sir presenting examination.
summarize it actually. We have to discuss the operative.
Myself, Dr. Anup, I am presenting investigation and operatives.
What's your name?
Anup, sir.
Okay.
So you have taken the history, everything done, examination, investigations, everything done.
Yes, sir. Yes, sir. Yes, sir.
The paper after.
Okay, sir.
You can use the paper too much speed, then afterwards we see the paper.
Okay, sir.
I hope you written down.
Yes, sir.
Okay, let's start. As Dr. Tendulkar says, relevant findings in the history to support your diagnosis.
My case is a 57-year-old male. He's Narayan Swami hailing relevant findings. 57-year-old male with
57-year, okay.
Complaints of dyspnea on exertion, progressive from 6 months, and complaints of chest pain from 6 months. Dyspnea on exertion was insidious in onset, has gradually progressed from NYHA grade 2 to grade 3 over the last 6 months. That is, he's able to walk, his walk of 1 to 2 kilometers approximately is limited with dyspnea, and it is relieved on rest.
1 to 2 kilometers, nobody understands.
NYHA grade 2 to grade 3, sir. Over the
Flight of stairs, can he
2
climb?
to 3 flights of stairs, sir. 2 initially at 6 months, now grade 3, sir.
You can climb 3 flights of stairs. Now you can't climb.
He can't, he's unable to. Then
You're on relative findings.
complaints of chest pain of non-radiating type, constrictive, which aggravated on activity, NYHA grade 3, and is relieved on rest. It is also associated with easy fatigability. No complaints of palpitations, syncope or pre-syncope. No, he's suggestive of infective. Relevant, only dyspnea on exertion and chest pain associated with easy fatigability. Then
So physical examination is taken by somebody else.
Yes, sir.
Also know the
I also
findings.
Yes.
Or you want him to tell physical
can-
findings, relevant findings. You want him to tell? Yes. Go ahead and tell. What are the relative findings in physical examination?
Sir, on general physical examination, the patient has a moderately built, well nourished, conscious and cooperative. In relative findings,
You're
sir.
giving
Yes, sir.
Just the relevant findings better, and
findings in
just the
physical
relevant things.
Yes, sir. So the heart rate is 84 with slow rising, late peaking pulse, low volume pulse, with a BP of 120/70. So no low diastolic and no pallor, no icterus, no cyanosis, clubbing, lymphadenopathy or edema. There was a carotid thrill that was appreciated on general examination, and no raised JBP. So I'll go to systemic examination, sir.
You can go wherever you want.
Why that thrill?
What does carotid thrill mean to you?
Sir, based on the history, this could be a valvular disease and yes, sir.
Carotid thrill. What does it tell you when you feel a carotid thrill? What is the impression that you're getting? What is the problem? What is the pathology?
It could be a organic aortic valve lesion, most likely.
Organic?
Aortic stenotic lesion that causing or aortic lesion.
When you tell anybody carotid thrill, they don't get that impression. You know what your diagnosis is. That is why you're sticking to your diagnosis, no?
What is inorganic? What is inorganic aortic stenosis?
So, not if it is a flow related or a functional hyperdynamic.
Flow related.
No, sir, not inorganic. Functional and inorganic.
Okay. Dr. Bashi has also joined. Good.
Yeah, I am here.
Or
Hi,
there could
sir.
be any carotid stenosis
morning.
or any carotid pathology also we have to rule out.
Remember Dr. Tendulkar's idea? You should think of the important things first and common things first, no?
Yes, sir.
Why are you saying because it is because of aortic stenosis? You don't know that yet.
Yes.
You just felt the carotid and you're seeing a thrill. What comes to mind is carotid artery stenosis. Now you got that. Okay.
Sir, on systemic examination, on inspection, there is the shape of the chest.
Relative findings. Do you understand the meaning of relative findings?
Yes, sir.
You're not giving the whole. You want to cut short the history part because you've already done it before.
Positive and negative findings.
Yes.
Yeah. Relevant means
Summarize the whole thing.
Yes. Okay. So there is on inspection there is a
Summarize again. Don't go back to inspection, patient percussion. Just summarize, beta.
Is there anything relevant to your diagnosis?
There is a suprasternal pulsation is visible on
There is
inspection.
suprasternal pulsation. Okay.
And the on apex beat is at the left fifth intercostal space. It
Apex
is not
impulse.
displaced. Apical impulse is at the left fifth intercostal space at the midclavicular line with a heaving type of apex. There is also no palpable heart sounds, but there is a palpable thrill in the right second intercostal space. And the relevant history, on percussion, the heart borders, right heart border is corresponding to the right sternal margin and the left to the apex. As on auscultation, there is an grade 4 ejection systolic murmur heard loudest in the second intercostal space, radiating to the neck with late systolic peaking. And what is systolic peaking? And
What else?
the S1 is normal. S2 split was not appreciated.
You should tell something in that murmur. You said it's late systolic peaking. What else did you say?
Harsh, grade 4, loud.
Called it anything else?
Radiation.
Told that I can have a heart.
Harsh, blowing, long ejection system.
How much?
More than almost 60 to 80% of the systolic. 2/3 of systolic. 2/3 of systolic. And other clinic, no other relevant clinical findings after this.
Okay. Based upon her history, relevant findings in history, and his relevant findings in physical examination, what is your clinical diagnosis? You have to use information that they have spoken, not what you think they have said. Okay?
Yes.
What they have said based upon that. So you have to use the Tendulkar method here. What all did she use? Words, keywords. Based upon that, you have to use Dr. Prasanna's method of giving the morphology, right? Can you do that? Try
Yes,
to do
sir.
that. Huh.
Patient with the history of dyspnea on exertion and chest pain. That is gradually progressing from NYHA grade 2 to 3.
What is their impression?
So, with the associated EC fatigability, I'll think of a stenotic valvular lesion.
Okay.
Did dyspnea come first? Or did
Patient first had dyspnea chronologically, followed by chest pain since 4 months.
Did you ask for any history of syncope?
There is no history of syncope, sir.
Did you ask?
History of palpitations.
If there is dyspnea first and then What is it? Dyspnea first and then
Chest pains.
chest pain or chest pain first and then dyspnea. What would be here?
He gives both a 6 months. He is not.
So almost more or less at the same age.
Then don't say that. Then that both you became symptomatic with chest pain and dyspnea at the same time.
Age was different.
57-year-old, sir.
If dyspnea occurs first and then chest pain occurs, what would you think of?
Mitral stenosis.
You think of mitral valve disease.
Mitral valve disease.
Where dyspnea is the predominant disease, whereas syncope and other things, if they come earlier, it is
Aortic valve lesions. Then on examination, radial pulse is a slow rising, peaking pulse with on systemic examination, there is a apical impulse felt in the fifth intercostal space. On palpation, there is a heaving
Something
type
else
of
about apex beat that he said.
heaving type of apex beat.
So you have to do a Prasanna cinema on that. What is the pathology?
Pressure overload states.
Pressure
Overload state of left ventricle that causes the prolonged systolic ejection.
Why is the pressure overload on the left ventricle? Because of what pathology?
Stenotic LVOT. LVOT obstruction.
Aortic stenosis.
Aortic stenosis.
When you say that, it takes care of the whole thing, no?
Yes.
I have one question. You said that there is dyspnea in that diagram of the heart which you made. Can you account for it? There is a patient who has had dyspnea. You are saying it's a small heart and he's having dyspnea. You have to
Because
build a
of
picture.
the raised LVEDP.
One is possibility of
cause
raised
LA
LVEDP
pressure
or
that causes the back pulmonary venous congestion.
or
MR, sir.
concomitant mitral valve disease. It may not be a severe disease, but it may be severe in the presence of the aortic valve disease that may become significant. Think always possibilities.
Okay.
On palpation, there is a palpable carotid thrill, and the palpable thrill is present in the right second intercostal space.
Means what? Now,
second right or left?
Right, sir.
Right intercostal.
Means what?
The lesion will be organic.
One is organic, and you are saying it is even palpated on, and it is well felt right on the right. And did you percuss the right heart border?
We percussed the right heart border, sir. It corresponded to the right sternal border.
And the thrill is extending where?
Thrill is extending up to the carotids.
Into the carotid.
You can feel the carotid thrill.
Aortic sounds on the right side of the sternum and aortic side sounds on the left side of the sternum. What is the difference to the cardiac surgeon?
So can I get that question repeated?
One patient, all this murmur, etc., you heard in the first aortic area, that is the left third intercostal space. And another patient, you are hearing it in the right second intercostal space. Same findings. So what is the difference?
Left intercostal space could be pulmonary one.
Could be. Both are aortic stenosis. What is the difference in the pathology?
Pathology. One is
Since
here,
yesterday we are constantly telling you every word you speak, there should be some hemodynamic, structural, anatomical relation. This is an anatomical relation.
I'll ask you the question again.
Yesterday, plain X-ray test, I told you upper right heart border, prominent could be SVC or aorta. So if you are hearing a murmur on right side, means aorta is dilated.
That's why I asked you that question.
So don't just keep on telling second space, third space.
Another thing that
has a meaning.
Yeah, another thing that you have to tell is where was the site, whether it is upper or is it lower? Why? Why?
It will tell the
whether it is valvular or all that. Now, another thing that you have to tell, which you may have to mention, is can you tell any other negative finding? I tried to auscultate it. I did not get it, sir. What did you try to auscultate in this case and did not get it, sir? Yeah. What are the things that you did not get?
Split of S2.
What about the split? Was it narrow, normal, paradoxical?
In this patient, we couldn't make out was soft.
Say that I
soft.
you have to what does a soft S1 mean now?
S2.
Everything is got A2 is soft. A2 is soft.
Because of the murmur, it could be.
A2 is soft.
Severity of the lesion.
Really? There is
Mass
aortic
because of
stenosis which is non-pliant. And then anything I want to click and you should give me the answer.
Ejection click.
Who's going to tell that?
Valvular.
I tried, I could not get it. If there is a click, it points to valvular origin. You may not be able to get it, but you must tell, I tried, but I did not get it. If there is a paradoxical split, what does it mean?
Severity of the
See, those are things. I searched for it, I could not get it. Some of the things may be relevant. Okay.
So on auscultation, there was a ejection systolic murmur heard in all areas, but more prominent in the aortic area, which was of grade 4, and late peaking ejection systolic murmur that radiates to carotid. So with all this,
can I stop him?
Yes.
The murmur is heard in aortic area and widely all over the pericardium. So you should always start from these 4 areas: tricuspid, mitral, aortic, pulmonary, and heard all over. You are starting heard all over the pericardium, and wrong way of thinking. Heard in the aortic area and widely conducted all over the pericardium and to the right.
Because next week, what will happen if you say that? They will ask you what is the difference between conduction and radiation.
Yes.
So you get into those problems.
So just to simplify it, as an extension of what they're trying to tell you is, when you're talking about a murmur, there are 8 things that can be said about a murmur. And one of the things that they're trying to tell you is, when you hear a murmur, you could hear it all over the pericardium. So the word that you have to use is heard best at which point. Heard best at which point. Once you say that, then it gives you an idea about where the pathology is. It might radiate and all over the place, conducted all over the place, but where it is best heard will tell you which valve is affected, right? Or where in the valve it is affected, or which outflow tract. So you have to start with where it is best heard. Okay.
Another thing, as a cardiac surgeon who is going to try to operate such a case, what is the additional murmurs that you would like to have thinking in the form of CPP, myocardial protection, everything? What is the other
late early diastolic murmur because
I searched for it, I did not get it. Of what?
Aortic regurgitation.
Okay.
Okay. So the history part is over.
Examination.
Diagnosis part is over. You rang the bell, did you?
X-ray, ECG.
You have to go to the investigations, right?
Yes, sir.
Yeah, sir. Please.
Can you please put the X-ray?
So 57-year male patient with
would you like to ask for an ECG or an X-ray chest first?
I would like to ask for an ECG.
Huh?
I would like to ask for ECGs.
Why?
Why?
Why do you want the ECG first? Is there any doubt in your clinical diagnosis that you want to solve by ECG?
Because he also had a complaint of chest pain.
And what will happen in a patient with the severe AS?
We'll have a
resting ECG will have strain, no?
Strain patterns.
So you asked for the ECG there.
Yeah, we got the ECG. Now tell me, as a cardiac, there is LVH. I'm telling you now, as a cardiac surgeon who is going to take this patient potentially for surgery, can you tell me what is your concern in this ECG?
There is a M pattern in the V5 LBBB left bundle branch block. In the V5 lens.
Tell me it's surgical. Now tell me what are you thinking in your mind when there is a widening of the QRS?
You speak in the mic, please. Yeah.
So that might imply that there is some calcification at the membranous septum area. So while decalcification, we'll have to be careful in.
I decalcify, but what else? Now, next, what are the other things you will counsel the patient?
For permanent pacemaker.
There's a potential for a permanent pacemaker.
Next investigation.
So in this ECG,
No. We've done this. Now we know.
Next, show the X-ray, please.
next I'd like to get a chest X-ray.
What is his age?
Can you
57-year male
just
patient.
hold on? Can you come here and talk about the X-ray chest? We have to evaluate all of you, no? So you take turns to go around. Okay.
Are you sure? That is what I'm going to ask this question. Are you sure it is the same patient, number one? No. If it is the same patient,
Then your examination is wrong.
No,
because the heart is big.
This is not the X-ray we saw in the ward.
It is not.
Oh, this is Karampreet.
No.
We
He is
saw
not.
the
They have
ward.
put this X. They have put this X-ray now.
We have the picture of X-ray.
Can you बराबर X-ray डालने का है? Okay, but I'm going to ask you this thing. Why did we all say this is not this patient's X-ray?
CT ratio is large, and then stenotic aortic lesions, they won't be cardiac.
Then what else is there? LA is large. Aortic knuckle is prominent. The lung fields, see the lung field?
Okay, let's go to the echo now. Where's the echo? I want to see that.
In the X-ray, as a surgeon, what would you like to see? Or predict the X-ray of this patient?
So they'll have a small aorta. They might have aortic knuckle can be dilated with calcification. CT ratio will be normal. It will be around 0.5. There will not be any atrial enlargement.
Now what? Aortic knuckle?
Aortic knuckle can be prominent.
Not can be, will
be prominent.
Ascending aorta and aortic knuckle prominent. Then?
And they will have to look for any calcification.
Okay.
Apex will be LV type.
No, don't jump.
MPA
Everything is important in this patient. MPA segment, what do you think in this
will
patient?
not be prominent.
No, you are having dyspnea. So I will very carefully look at the MPA segment. Then next, LA appendage.
LA appendage can be enlarged in this case.
Very likely to be enlarged because you're saying dyspnea. Then next.
Apex will be an LV type of apex.
Okay.
And
LA may be enlarged.
LA.
And then more important, as a cardiac surgeon, what are the things that you're going to see specifically in this X-ray?
The calcification of the valve and the...
Where do you see the calcification?
Annular calcification, if you can see.
Where will you see it?
The ascending aorta and the knuckle.
And in the annulus?
Annulus calcification.
Where?
Which part of the
How do you determine that calcification is aortic or mitral?
The right, the line we draw from the right cardiophrenic angle to the left rib, mid of the left third rib. If it is above that, on the parasternal area, there will be calcification. That will
if
be.
I want to confirm that this calcification is actually calcification and not some.
Get a CT.
CT, okay, or else fluoroscopy.
Fluoroscopy.
CT or fluor. Would you like to get a CT for this patient? Yes or no?
This patient, no, I would.
No.
I mean, it won't.
I would very likely, you are telling me that their conduction system is wide and other thing. There is very likely to have extensive calcification. And calcification here can be a marker of calcification in other parts of the aorta.
Okay, get a CT. See this.
Okay.
Look at this. I will just ask one question, sir. Looking at this thing, compared to your original diagnosis, look at this thing and tell me how is your management going? Plan your management.
You've seen the echo before?
Yes, sir.
You read the whole thing?
Yes, sir.
Okay. So now,
how is your management going to change compared to a standard AVR for severe aortic stenosis? How is your management going to change?
Firstly, starting from the beginning, we notice LV dysfunction. Then aortic regurgitation
LV
is there.
dysfunction, EF is 50%.
EF is 50%.
Yes, sir.
I'm telling,
Requires
compared
LV
to a
protection.
standard AVR, how is
there's
this
aortic-
echo going to change your management compared to a standard AVR?
Let me ask this question slightly more specifically so that you understand what the question is. In this reading this echo report, what are the echo report specific findings that will alter the way you will do the AVR? From this, you have to pick out those numbers based upon which it
So
will
annulus
change.
aortic annulus is 18 mm. So we should plan for his BSA what is the valve to be planned, and if he requires root enlargement or not.
Okay, got it.
Then aortic regurgitation is there mild to moderate. So while giving cardioplegia, I will either clamp the LVOT, hold the LVOT, or plan for retrograde or fibrillatory arrest and then direct ostial cardioplegia.
Okay.
Then ascending aorta is normal, 30. No, I will not
Okay, let
intervene.
me ask you a few questions now specific to this. You are seeing what is the gradient across the aortic valve?
Mean of 55.
If I want you to comment on that gradient and the LV function, do you want additional information or anything else you want from me?
Peak velocity,
No.
a valve orifice area.
No, I want to have the previous echo of the patient. A rising gradient means what and a falling gradient means what?
A rising gradient shows progression of the natural progression of the disease. A falling gradient shows that because of patients going into failure with a low flow, low gradient
The LV is backing up.
dysfunction.
That is not able to generate that much pressure. That is why the grade, if the previous echo shows gradient and if the next echo shows gradient is falling, you have to be very alert.
I have a question. I'm seeing that the LVIDD is 66 and 50 with severe AS, with moderate AR and EF of 50%. Can you comment on that?
Yes.
So it is a mixed lesion of regurgitation and stenosis.
Even then, I'm asking you a question. Even if it was a mixed gradient, 66 and 50, are you happy, unhappy? Do you believe this report or would you like a review of this report?
Hello.
Like a review.
Let her answer. If he doesn't answer, you answer. Got that bit?
Have you understood what sir is asking?
Yes.
Their number is 66 and 50 and the EF is 50%. And you say that the heart was small. And now I want to ask you, looking at these numbers,
I'll ask for a review echo to look at the LV dimensions again.
what do you think? Why do
I
you
will
suspect this 66 and 50?
I will expect a smaller.
One is you expect a smaller one. Do you know what is the fractional shortening in this patient?
Okay.
Calculate. Quick. 66, 50. Calculate. All students calculate the fractional shortening. No yawning. I'm not interested in seeing your absent third molars. I hope you got the answer. If you understood. They did not understand, sir. Anyone understood? I'm not.
Third molar is referred to as the wisdom.
26%. It is low. Anything below 27 is definitely low. 24 actually. It is coming to 24 actually, if you calculate.
Do you expect that the LV ID will be not 66? Looking at the entire echo? In a patient with aortic valve disease, which is stenotic, why would you have a LV ID that is so big in the echo report? Is there anything that suggests that LV ID can be big?
Regurgitation.
Yeah, aortic
But
regurgitation
how much
is there.
the regurgitation? It is
Mild
only
to
mild to moderate. Now, given this, what additional information would you like to have? Let us assume that everything is correct. Given this, what other additional information, what other investigation or anything would you like to do?
Angiogram. And
One is
MRI
coronary angiogram. Why?
to look at LV function.
LV function I have 50%. You think in this case you will do a LV angiogram? What did I tell you just? If you do a LV angiogram in a patient with a 6650 with AS, the patient will collapse on table. Yeah?
Coronary angiograms.
Coronary angiogram, I will agree.
What about the aortic cusps? You said bicuspid, tricuspid, you not bother?
I look for it on the CT scan, sir.
You look for it on the CT scan. Now, you open your mouth so wide, you'll put both your feet in it.
Sorry. MRI.
No.
No.
If it is not
On the echo, you could say no, but if it is highly calcified, agreed. The 3-Mensio software today gives you whether it is bicuspid, tricuspid very reliably. In fact, on gross looking of the echo, you may not be getting it, but with the 3-Mensio, I think you people may or may not know what 3-Mensio. 3-Mensio is a software which is used in TAVIs, sutureless valves and other things, which very, very, very accurately gives you the whether it is bicuspid or tricuspid, because it matters a lot for people putting sutureless valves or doing TAVI. Any other thing, I have got a concern in this patient that this patient, does this patient, can an AVR be done in this patient? Yes or no?
Yes, sir.
Why are you saying that even despite that 66 and 50, I want to do a AVR?
There will be reverse remodeling after the stenosis is relieved. And
The gradient is still high.
Patient will benefit.
It is above 50. Whatever may be the LV, this patient still
will
gets
benefit
a
from
chance.
AVR.
When will you not operate a patient with severe aortic stenosis?
Yeah.
Yeah. You don't know? Pass
No, I
it on
don't.
to somebody else. Yeah. Pass it on to somebody else. No volunteers to take the question.
When that
It comes to here.
that is one of the most difficult exercises in cardiology, where that whether you are trying to show whether it is low flow, low gradient AS, and for that they will do a dobutamine test. And if you have no increase in the gradient, those are the patients you will not go to offer surgery in. Otherwise, you will offer, even with, we have operated with 20%, 15%, but you relieve the aortic stenosis. But what is the caveat in such a case?
So let's.
You might need to put them on ECMO or LVAD.
No. Myocardial protection must be careful.
Also, angiogram is normal for this patient. Everything done. Let us discuss surgical.
Yeah.
Yeah. So how will you proceed now? Patient position.
Investigation is done.
We are doing aortic
is
valve
normal.
replacement.
So now who came for surgery part? You. Okay, come here.
Midline sternotomy done. Pericardial stay sutures taken. Okay.
Why not MICS?
This patient.
No, MICS, let them get to the root normally first. Then they can decide about MICS.
This case, would you like to do MICS? Are you going to do MICS?
No.
Patient says, I want a small incision. Would you do this? Please
No,
tell.
sir.
Tell no.
No.
And tell I'm a. One is beginner and LV dysfunction.
LV dysfunction is.
Number two, I want before. How you are putting this OT list, you are going to go to Jumrutalaya Medical College and you are going to do the case. What are the precautions you do before you even start the case?
Before you make your skin incision, what precautions you will take?
Before madam comes into place. Madam is my wife.
Pump
has to be kept ready. Prime has to be
primed and kept.
Prime. What about the prime?
Blood prime.
Yeah, we welcome Dr. Sampath Kumar and Dr. Bashi online. Sir, be free to ask questions, sir, in between.
Yeah.
Going on.
Questions are asked.
Echo has been done, sir. Echo discussion over, sir. Just over.
They have got a patient with AS with significant LV dysfunction who is on the table.
Okay.
With AS moderate AR 18 57-year-old 18 mm calcified annulus. Continue.
Before induction, we would like to keep the pump ready and blood primed.
Blood primer. Why?
Do you guys know about blood conservation?
Why blood prime in this patient?
Any reason you have in mind?
What is the reason you think of blood prime in this patient of all patients? He's 57-year-old, big man, normal hemoglobin. What do you do with the prime? Not only is it pump is ready, what about the prime? It is kept warm, normocalemic. Because a gush of cold blood can?
It will fibrillate.
Then another thing, What else in Jumratayalaya Medical College? What is the other thing that you will do? Pump is kept ready then before induction.
What will this? You're a surgeon, no?
Surgeon,
You tell
what
what
are
a
you going
surgeon
to
going to do.
You be washed
Then
and
be washed and
ready.
ready.
Why?
During induction, patient can fibrillate or arrest. So immediate sternotomy has to be
Why?
done. Because of the fixed cardiac output.
Have you seen any
The
patient
anesthetist
fibrillate?
was about inducing these patients.
Have you seen any aortic stenosis patient fibrillating after induction of anesthesia in your center?
Yes, sir. Once.
Did we hear the question?
Yes, speak loudly.
Yes, sir.
What was done there?
Sir, CPR was given immediately.
And really,
And
more than CPR, what was done?
Heparin. You give heparin and go on bypass.
Go on bypass pass. No, they rush to go on bypass.
Yes,
right?
sir.
They are
Give
not
heparin.
salvageable cases by.
Most important thing after giving heparin, everybody forgets is you have to. Important thing is to massage the patient.
Yes.
So that otherwise
That's
after
right.
resuscitation you will get a fully dilated pupil. Very important. Heparin, massage one hand, ask somebody who is senior person to come. If you are more normally the senior surgeon would not have it scrubbed up. Oh, maybe busy. So get our help immediately. Heparin and massage till you get somebody. If you are not confident of taking a purse on an aorta, because aortic stenosis, the aorta will be thin. So call for help immediately. Okay.
Yes, sir.
Continue.
So under general anesthesia, after monitoring links placed, median sternotomy
So
is done.
sternotomy done, pericardial stay sutures taken, heparin given, then
Then aortic pulse strings are taken.
In
and
2025, what other precaution will you take in 2025?
higher up of
2025. Calcific aortic stenosis, wide QRS. What did you tell?
Epicardial echo.
You can do an epicardial echo to determine the site of cannulation. You may have calcified spots which you don't want to clamp on. Continue.
so you have taken the aortic cannula, you have taken the venous cannula, then what will you do?
aortic cannula and RA pulse strings taken, cannulated. We'll go on bypass.
What
Then
precautions will you take when you go on pump now?
ACT to be reached more than 480.
No.
What instructions will you give the technicians, the perfusionists?
When you go on bypass, what can happen?
Same question was asked at the beginning.
You are keeping the pump volume warm, no? Why?
Because heart can fibrillate.
Okay, you have just gone on pump and heart has fibrillated. Then what do you do?
We'll vent the heart.
Answer my question. You have gone on pump and the heart has fibrillated. Now tell me exactly what all steps will you do for this patient?
We'll put an immediately take an RSPV pulse strings and vent the
Pulse string. The heart is fibrillating. Remember, you have got AR.
Suture not available.
Clamp the aorta, open it, because that will vent the heart. And
So
that
what will be your steps of managing this patient if you have gone on pump and the heart has fibrillated?
we will apply, we'll ask the perfusionist to decrease the flow and we'll apply the cross clamp and we'll do the transverse aortotomy 2 centimeter above the RCA.
Okay, then?
Then we'll put a sucker into the left ventricle
and then
to decompress.
a pump suction in the left
pump
ventricle,
suction
then?
left ventricle and we'll give the ostial cardioplegia.
But you think it will be so easy for you at your level to put a suction across the aortic valve and give cardioplegia at the same time? Anyway, any point, anyway, is there any other way you can take the blood out from the left ventricle? So what will be your steps? See, this is a one question which will be asked to you in the exam. Going on pump and the heart fibrillates, what are your steps to manage this? Anybody?
Take the
Are you on a two-stage venous cannula?
Two-stage venous cannula.
So how can you take the blood out? By stabbing the RSPV. How can you stop the regurgitant volume? By cross-clamping the aorta. How can you make the ostia visible? By making an aortotomy. Once the RSPV is taking the blood out, the aorta LV will be empty. You can see the ostia, you can give cardioplegia. There's absolutely no reason for you to panic, but you have to think in those lines.
So you understand the sequence of events, no?
Yes.
And the reason why the sequence is important. You got it?
Yes,
You
sir.
understood, no?
Yes, sir.
After you've arrested the heart, then you can put a vent properly in the LV and proceed. But you have managed the fibrillation. Don't say that you will shock the patient and all. You may not be able to revert the fellow back at all.
Okay, sir.
So patient fibrillating going on pump is the standard question for you for aortic incompetence when you are presenting in the exam.
In all this, don't forget you have got a hand to massage the heart.
That is what I want.
Because if you will be told clamp not on table, first thing not on table, but what is on table are your two hands. So use your
grab
hands,
your LV.
very huge heart and massage. Most important, avoid LV distension.
And all the more in this case where you had 66 and 50. If it dilates, it is gone.
Okay, now let us make some progress. Heart
And
arrested now, whatever is there.
Sir, another thing for the perfusionist to keep ready is cardioplegia.
Yes, sir.
Must be ready.
So you have given ostial cardioplegia, heart arrested. Yes. Last 10 minutes, huh? Okay, so they will discuss decalcification and precautions to take for excision of the valve. Two things.
Perfect.
Dr. Bashi, anything else, sir?
No, one important thing I want to tell the students is when you are starting your surgery, most important is preparation. Because when you are posting a case at 8 o'clock in the morning, operation doesn't start at 8 o'clock. It starts 8 o'clock on the previous day. You have to study the case, talk to your nurses and perfusionists, the problems which you can encounter, and be prepared. Because there's a famous saying by Abraham Lincoln, if I am asked to cut a tree and given 10 hours, 8 hours I will use for sharpening my axe. So that is very important.
Also, if you don't mind my saying, get the pump ready. Keep your cannula on the table. You divide the cannula, connect the venous cannula, connect the aortic cannula, and keep it ready before you open the chest. That way you will save time when you need to go on bypass urgently.
Okay, sir. So once the aortotomy is done and heart is arrested,
now we
so we'll proceed with the decalcification. I would like to start the decalcification with the scissors.
Decalcifying with
scissors. What is the first step before you
we'll
start?
have to take a number 11 blade and...
No, before that. What is the two steps that we do? Yeah.
Put a gauze in the LV.
Yeah, you can crack open and put a gauze in the LV, number 1. Number 2?
We'll put the plegia in cardioplegia cannula in the ostia, left ostia.
Why?
To protect the, to not allow any embolus and injury to the ostium.
Not injury. You don't want calcium to fall into the left main ostium and into the LV. We're a big hunt.
Marker pen, please. Marker pen. Go ahead.
Then we use a 11 number knife and stab at the middle of NCC and excise.
No, NCC, RCC,
non-coronary cusp.
Are you going to do anything before excising the aortic valve?
Stab under non-coronary.
Right, RCC, sorry.
There are 3 leaflets. Once you say non-coronary, once you say right coronary, and left. What is the principle of doing the first stab? If you know the reason for the principle of doing the first stab in mitral valve replacement, aortic valve replacement, what is the tricuspid valve replacement? What is the
best visualized and safe?
No structure underneath it, which the tip of the stab. You are not seeing anything. I am putting a blind stab. So if I put it in NCC, what will happen?
Bundle.
Not bundle. What will happen? Mitral valve is down there. Bang there, mitral valve. LCC, God save you. It will be going into the transverse sinus. The only safe place is the RCC side.
Dr. Sampath Kumar, you wanted to say something?
Yes. Before you excise the aortic valve, what are you going to do? Before you even take a lemon blade to excise the valve. How do you deliver the valve into your incision?
Yeah.
Stay sutures.
Where are the stay sutures placed?
Yes.
The three commissures.
You stay 3 stay sutures at the top of the commissures and you pull it up to the drapes. The
And
valve
fix it.
will come up for you to do excise. Then first thing you put a little gauze piece, wet gauze piece into the left ventricle and keep it underneath the aortic valve. And put a cannula in the left coronary ostium. Then you start excising the valve.
Excise. Excise the valve.
You're from which institute?
All three musketeers from mine. मेरे बच्चे नहीं है.
Who is not your bacha? You can call them. You're also
This
from
side.
Jaideva?
Gang.
Both of you are from Jaideva?
That's why I said
All three
मेरा
of you
बच्चे
from Jaideva?
gang warfare, no?
Sir, then you cannot ask questions. You will ask all the questions that they already
No,
got. the
I'll ask
answer.
them the question they don't know. Gangs of Vasaipur.
When you give cardioplegia, let me ask one question. In a coronary direct cardioplegia, what do you specifically look into that? Because you have previous coronary angiogram you have done. What one anatomical abnormality can be there in a left main?
Especially if you are dealing with a bicuspid valve.
What is the thing that you would see in the coronary angiogram, sir is asking, that can be of concern when giving left ostial cardioplegia? Sir asked that. You have to give the answer in a short and precise
If you see the angiogram,
manner.
if the left main is short,
Short left main will be.
that is the
What will
answer.
happen in a short left main?
The cannula will go down the
It will go to which branch?
Go to the circumflex.
The LAD is like this, it is going like this.
In the
and this side is the circumflex. You may be giving there and not giving anything to the other coronary.
It's very important, especially in a sick patient. And another technical point which I want to stress is when you're giving cardioplegia to the coronary, one has to be very, very attentive and you should not push too much, don't put too much pressure, especially in thin coronaries, you can dissect the ostia. You have to be meticulous and attentive in looking into the ostia when you give, and don't use very stiff ostial cardioplegic catheter, which can injure the coronaries. It may be a catastrophic problem. After releasing the cross clamp, you will be looking at the ECG if you are not careful. No point in looking at that time and finding out ST segment is elevated. So these are very important life-saving things you have to be very aware, and especially in a sick patient.
So now he's going to demonstrate how to decalcify on the image here. I don't know whether you can see the image.
Very dangerous, sir. Yeah. Take mic, please.
Can you have darker color for photograph?
Yeah, I think it's
So
better.
with the number 11 blade, I like
Okay.
to stab
I'm
at
really worried
the RCC.
Then what do you do?
Then we'll take the scissors and we'll cut at the RCC
Now,
LCC
what is the
commission.
curve of the scissor like?
The curve directed towards the lumen.
Ah.
And
Parallel
to the
parallel to the annulus.
annulus. And we'll start with the NCC RCC commissure and decalcify it towards the RCC, towards the
Not decalcify, you are saying cut.
cut
is
the
different from
leaflets.
decalcify.
Scissor is used for cutting.
We'll cut the RCC leaflet towards the RCC LCC junction and the RCC LCC commissure, followed by we'll again continue the removal of excision of the LCC leaflet towards the
Alle bidda maga.
Where's the ostium?
You were cutting, but then something went wrong.
From here,
मेरे बच्चे
are
नहीं
you
पढ़ते
supposed to be
मगा.
cautious? What precautions will you take cutting the cusps on each side? Here, what will you protect? Nothing much, I suppose. What is your precaution here? What is the precaution here?
Left ostial.
Left ostial you injure?
Something
means you should give up cardiac.
No, there is something really bad.
Yes.
I told you all the problems are down.
It can transverse into the
No, you can open the
into the sinus.
which sinus?
Transverse sinus.
Thank you.
So, but from where to where is the transverse sinus for you now?
It's on the from the commissure to the.
Not at all. It's from here to here.
Here.
When you put your finger and feel both the great vessels, your fingers are in the transverse sinus. So from the left coronary orifice till this commissure is the
Transverse sinus.
transverse sinus. We have to be very careful here. So one precaution here. One precaution here.
To be careful not to go deep.
For the conduction tissue.
tissues.
Here, what will you damage if I was supposed to ask you to draw the mitral valve? After the valve is excised, where will the mitral valve be?
Draw the mitral valve on this diagram.
Mitral valve, where will it be after the valve is excised? You have to have the LVOT, the aortic valve from below, from up, everywhere.
See the aorta mitral continuity here.
Where? Only this much, huh?
And mitral valve behind.
Where? From where to where?
From midpoint of the LCC.
Little beyond that also.
Yes. 2/3 of LCC.
Connected here.
2/3 of NCC.
And where will the interventricular septum be?
Septum.
Interventricular septum.
That will be in the.
Here?
Where do you do LVOT resection?
Anoop's diagram.
Where will the septum be? Septum is attached to what? The septum will be when you are opening this, taking out the aortic valve for Hookham resection. Where do you do the resection? The septum is here. Better put everything together. You're not going to bite you.
Worse on them than
So you have decalcified the valve.
others.
Yes.
Everything done. Sizing of the valve.
So once the decalcification is completed, we'll take the adequate.
Excising, decalcification is a different thing.
So actually,
excision.
you have decalcified the size.
Can
There's
you
no
just,
time.
Sir, we'll just ask one question. How do you decalcify? Methods of decalcification.
We'll take the ronger and we'll crush the calcification part and twist it.
Twist it. One twisting. Crush. You can grasp and twist.
Grasp and twist.
Any other? What are the methods?
Enumerate different methods.
Kusa we can use.
Kusa we can use
Okay.
to extract.
They better say because our hospital is using it.
Say it loudly because people are online, huh?
The dental.
You say that ultrasonic debridement can be done.
Say it loudly, man. Don't mutter.
Cavitary ultrasonic device.
Okay.
You are using?
Yeah. We have
yes.
described. We are using.
Yes, sir. Yes.
We are using.
In our institute, we're using.
If you are using that, how do you use it? You said you used it. What do you do? When do you start the decalcification with the Kusa?
After near the annulus only.
Before detaching the leaflet itself. Have you seen? You hold the leaflet and you place the Kusa on the or whatever I use an ultrasonic scalpel because we don't have a Kusa, but it's the same thing. And you place it and you put it at the region junction between the calcific part and the non-calcific. The Kusa will not act on the fibrous tissue for those things. It will only act on the calcium. So you place it and you just wait. And you just, as you keep on holding it, the tip of the Kusa will start penetrating into the junction between the calcium and the soft tissue. You can remove extensively bars of with the Kusa. And those who have attended, when you saw, we got the actual Kusa for the Ozaki workshop for people who had seen it, and you could see that works very well, and you can remove the bars without fear.
What is this machine?
So now you have
if you cut here, you divide the conduction tissue at stake. Here, transverse sinus. If I just cut across here, where am I?
It's very common with students. They tell some technique.
If I just make an
ask
here,
details not known, then
where am I opening?
Construed as
To the
Tendulkar is
septum,
against that.
septum.
So you must know the steps.
This is typical. Suppose just now Somebody was asking minimal invasive approach. People are going to ask you details about that. Then you don't know details. Then you can say, Tendulkar operates from sternotomy. That's why he's against minimal invasive approach. So it is not against something. It is you not knowing the technique
anything
which you have talked. Just now only you talk and you don't know the technique. So how much marks?
Manpreet,
Exactly.
you got some more time?
Understood.
Time is over.
One
We
technique.
like to size some other aspects of this. For this patient, you have excised the valve. You know the annular size of this patient?
It was 18 mm, sir.
18 mm. Now, what else will you do here?
Now that is 18 mm valve, we have excised the calcium. Now what do you think is going to happen?
We like to size the valve with the sizer.
What do you expect is going to happen in this case?
If
Can I say
the sizer
something?
is not, we are not able to pass.
What do you expect?
Sampath Kumar sir wants to ask.
Sir is asking a question. Sir, please tell.
After you excise the valve, there is still calcium somewhere else underneath the aortic valve. Where can it be and what are you going to do about it?
It can be on the aortomitral continuity. Mitral leaflet can extend into the mitral leaflet. So
you are not audible.
Adequate excision will do, and with careful not to injure the.
Sir is saying something.
Calcification may not be in the cusp only. Where else can it be?
Sir, he has answered on the AML.
And anywhere else?
LVOT.
At the AV node.
Yes.
Ventricular septum.
You have to take it out.
Okay.
Sometimes it is deep in the ventricular septum, so you have to dig it out.
Okay, sir. Then you like
You
to
excised everything, you're debrided. Now you put the sizer. What sizer do you think you're going to start with?
We'll start with
First of all, mechanical valve sizers or biological valve sizers?
the 57-year-old male patient. So we like to
Explanation.
mechanical valves.
Mechanical. So what that sizer is called? There are three shapes of sizers. One is like a cylinder, one is like a replica, and one is like a hat. You can draw that three pictures. One is cylinder. Large cylinder. Okay, this is cylinder. Second is replica. And third is like a hat. My God, this is almost Picasso.
Okay. I think we'll go ahead.
Okay, go ahead.
If annulus is size, you are putting 19 is not going, no? So now go further.
Have a choice whether you want to proceed with 19 or shall I give you a bigger route to tell me the steps? Or you want to discuss route enlargement?
19 is going inside. Are we going to put a 19?
So for this patient's VSA, at least 21 is required. So I'd like to.
How did you arrive at that?
With the BSA, sir.
What is the BSA?
1.68 meter square.
1.68. So what size? 21.
21.
Okay. Now, what will you do?
I like to try to decalcify as much as possible.
Decalcify, done all
simple
that. Now
suture.
19 is going. Cylindrical 19 is going for mechanical valve.
Ideally, the measurer should be used after what step?
After purse strings. After sutures, sir, sorry.
Placing all the
sutures.
Okay, thank you.
Which side, what kind of suturing are you going to do?
I'm going to take non-pledgeted sutures all around.
Continuous?
Simple sutures, sir.
Simple U-shaped sutures.
Simple interrupted suture.
Interrupted sutures.
Or mattress. He's asking you U-shape. Are you going to take mattress suture?
Or horizontal
Let's take
mattress?
simple sutures, sir.
Simple sutures.
interrupted.
Simple interrupted suture. Use those words.
Simple interrupted sutures.
And you want to put a 19 size valve, right?
No, sir.
Okay.
So what will you do if you want to put that bigger size valve?
First option is
What
called
are the
something.
options for you? As a beginner, what's the simplest option? As a beginner, as a one option for you always is what is there?
Put the 19 inside and
Call your senior. Call your senior. Number two, I want to put a 21 valve. I've started 19. What is the simplest option for you? Whether it's right or wrong is a different thing. But what is the simplest option available for you?
Supraannular.
Tilted position. You can put one size. He wanted 19 and he wanted to put 21.
So, which side will you tilt it?
I don't understand this tilt.
Maya.
Away from the coronaries.
It will be in the tilted up in the non-coronary sinus. But then next, what other options are available for you?
You want to put a 21 now?
Yes.
Okay. What are the options available? You understand the question, right?
Yes, sir.
What option now can you do? What operation can you do?
You understand the question?
Yes, sir.
You start answering, otherwise they will go on to the next question. So
What
answer.
happens if you tilt a single, say the bileaflet and single leaflet valve is available. If you tilt a single leaflet valve, too much problem.
That was discussed, sir, Dr. Bashi. We talked of tilting. That was discussed.
Okay, Joseph.
The last option is root enlargement.
Not last option. The
Next option is root enlargements.
What type of root enlargement would you like to do?
Sir, NICS.
Okay,
incision
you would like to.
at the
Where is
midpoint
the
of
incision put on NICS?
midpoint of NCCs.
Fine.
At the which point of NCC? That NCC is midpoint of NCC.
Midpoint of NCC. Midpoint.
Okay.
Not extending
what
up to
are you
the
going
base
to
of
augment with? What are the you going to augment with?
This is the last question.
Pericardial patch.
Three of you, anybody ask her? After that, Dr. Sampath Kumar has to sum up your evaluation. Done, no? Sir, he said he will use pericardium to do a NICS procedure. Dr. Sampath Kumar, I think you have to give an evaluation of the performance of the students.
Yes. I think they have missed a lot of things. Unfortunately, they have to explain what they have seen in their hospital, what the technique they have used in their hospital. There is no use saying I will do mix and all that when they have not seen it at all. First, they must say what is the routine technique that they use in their hospital. Secondly, there are many precautions.
Institute will Ozaki procedure is also done.
No.
Manu.
Okay, sir. Go ahead, please.
Yeah, and it is important to know all the options available. You are saying mechanical valve or tissue valve. Is there any other option? For a 57-year-old
Ozaki procedure can be done.
isolated
Autologous pericardial patch.
Okay, he said Ozaki is an option in this. Yeah, then any other options? Sir is asking, you think Dr. Sampath Kumar is asking, so you must be thinking, in our hospital and the All India Institute, it can be done.
Homograph.
A homograph can be put. Okay.
Anything else?
Anything else? Dr. Sampath Kumar is there as examiner. Think, I'm giving you a clue.
Any other surgery you can do?
You may not want to do, but you may call somebody else. You can invite Dr. Sampath Kumar to come and do.
Ross procedures.
Ross is another option. Sir is asking different options.
Sir, Dr. Prasanna Kumar is very good at giving creative hints.
Yes. there is another option. Apart from homograph or Ross procedure, there is another option that is available in hospitals where you do transplants. So if you are doing a transplant, you can post this patient on the same day, take the explanted heart, take out the aortic valve and use it to replace the aortic valve and ascending aorta as a root replacement. That will be ideal because it's a living valve. It's almost like the Ross, and it will give the patient excellent hemodynamics, and it will also give him a valve without anticoagulation for life. So all these options you must mention. It doesn't matter if you don't do it in your hospital. You must be aware of what is available and what can be done for a patient about this. Secondly, you forgot to mention that you're going to cool the heart externally. You never said anything about putting ice slush on the heart. That is, external cooling is vital, especially in a patient with aortic stenosis. Apart from cardioplegia being infused into the coronary artery, you must use external cooling.
Yes. External cooling is very vital. That's why I call it Som Sukta. Don't you see? We put continuous drip based on Shamway technique. Cold saline is continuously irrigated on such hearts.
And it is sucked out.
Dr. Bashi, can you? Oh,
Wait
sorry.
action.
Sir, tell.
Yeah, tell me. Can you hear me?
Yes, please.
Yeah, what do you want to ask me?
No. Summarization of the candidate's performance by both of you.
Yeah, I think
the idea that they want to know, Dr. Bashi and Dr. Sampath Kumar, are they borderline pass or borderline fail or definitely pass? Final assessment, can you give some kind of an impression about this fact?
I will depend on how much they have learned from their own institution. If they can talk about the surgeries in their institution, what they do, how they do it without any prompting, then I would pass them. But if they are not able to tell what they do in their own hospital, which they have assisted, then it is a little difficult to say, yes, definitely pass. I would say maybe come back after 6 months.
Dr. Bashi?
Yeah, I mean, they have answered reasonably well, I would say. I would give them pass, I think, for what they have presented. Even though they have not told about I agree with Dr. Sampath Kumar, but I was listening to their early presentation and analysis of the X-rays, ECG, and clinical examination. I think I would pass.
Can I make a comment?
Yeah.
The boys are almost there. They just need a little bit more coaching and they'll be all right.
Yeah.
So can I do one more thing? Can I ask internal examiner whether they pass or fail?
I'm not supposed to be. My job is to try to.
Right. Okay, thank you very much.
One question to Dr. Bashi.
Yes.
What are those photographs behind you?
Pictures behind you, sir.
That is it's about 75 years old photograph. That is the history of medicine. I'm actually in a new house today. I mean, recently.
Welcome. Congratulations.
The history of medicine, all from anatomy, physiology, vaccine, all those things are about 56 photographs are there.
Next presentation will be that.
Yeah.
Your new house.
Yes.
So thank you, the students and our professors over here.
Teachers.
It was probably a comprehensive example of how to present a valve case. Would you agree? It's good? You happy with the presentation? Okay, fine. Over to you.
Thank you, sir. For the next case presentation, we have Dr. Jaydev and Dr. Prajita from Jayadeva Institute.
Manpreet,
You have forgotten your.
can you hear me?
You always say Apna Chaluna. In a different meaning, but
The examiner for this session are Dr. S.V. Shri Krishna, Dr. Ravinder Kumar Dewan, Dr. Ali Zamir Khan, and Dr. Shiv Kumar Swami. Sir, kindly chair the session. I'll just chair.
Thank you. I'll see you later.
We'll start by the time, sir.
And Dr. Ali Zamir Khan online? Not there? Okay. Yeah, go ahead. Manpreet madam is telling to do fast, quick.
Good morning.
Time is getting up, so do start quickly. She's telling me, scolding me.
Can you introduce yourself, please? Sir, I'm Jaydev, sir. And
Sir, Prajita.
okay. Start. Good afternoon, sir. Good afternoon, dear teachers and colleagues. I'll be presenting the thoracic case. My patient is a 76-year-old male hailing from Dodbalapur. He's a farmer by occupation. He had presented.
Little louder. Speak into the mic.
Yes, sir. Better, sir?
Yeah.
Yes, sir. Patient had presented with chief complaints of cough with expectoration for the past 4 months, with difficulty in breathing for the past 4 months, and chest pain since past 2 months. History of presenting illness. He had complaints of cough for the past 4 months, which was insidious in onset, and it was gradually progressive. And it was not associated with any postural variations, and it was worsening at night. It was associated with expectoration, which was also since the time of the onset of cough. It was also insidious in onset and gradually progressive. Initially, it was white in color, less in quantity. It had gradually increased in quantity and it has become yellow in color, and it is foul smelling. In initial periods, he also complained of blood streaking in the sputum, which was only one or two episodes in the initial period. He also has difficulty in breathing, which has gradually worsened since onset. It is worsening on less than routine activity with MRC grade of 4. He had 4, sir. He had complaints of chest pain, which had started 2 months ago, and it has also increased in severity since then. It is dull aching in nature, and it is aggravated on cough and relieved on rest. He has complaints of weight loss of about 4 kilograms over the past 3 months. Otherwise, there's no history of loss of appetite or any other complaints that might point towards a cardiac cause. Past history, he had prior to admissions at a private hospital due to similar complaints. This was about 3 months ago, where he was treated conservatively. He had not presented documents regarding the previous admissions. There are no history of any prior surgeries. He is a newly detected diabetic patient controlled on oral medications. Otherwise, he has no previous history of tuberculosis, hypertension, asthma, or any endocrine abnormalities. He is a known tobacco smoker. He had consumed about 12 BDs per day for about a duration of 20 years. He had stopped about 28 years ago. Otherwise, he doesn't have any other known addictions. Family history. He has history of tuberculosis in the mother, which he had during his childhood. To summarize, this patient is a 76-year-old farmer with complaints of cough with expectoration and difficulty in breathing for the past 4 months and chest pain for the past 2 months. And he's also having history of tobacco smoking and exposure of tuberculosis in the family.
What do you think with the history? You have to explain the different symptoms. Cough, age, farmer, cough, breathlessness, streaky hemoptysis, you said, and chest pain. So how do you correlate all this into the picture?
So,
what are the possibilities? We don't want a single diagnosis. Yes. What are the possibilities these things can happen?
I would like to consider a possibility of tuberculosis followed by any aspergilloma due to his history of being a farmer, and also there is history of blood streaking in the sputum. It could be an infective etiology due to yellowish discoloration of sputum with foul smelling and increase in quantity. Other possible differentials could include carcinoma of the lung due to his history of smoking tobacco for 20 years of duration. And also hemoptysis can also point towards a carcinoma.
Why did you jump into aspergilloma straight away?
I'm sorry, sir. I was thinking towards
because you know the diagnosis.
No, sir. I had seen the X-ray, sir. I felt it could be, sir.
You cannot say aspergilloma. See, tuberculosis also, they just cough and this thing, and then he's got purulent expectoration.
Yes, sir.
Which is an infective pathology.
Yes, sir.
So you should think more about infective pathology. And you don't get purulent sputum in aspergilloma.
Blackish.
Yeah, okay. So that is okay. First is the infective pathology. You might have a lung abscess which is going on. And why do you think he's got chest pain? Abscess cavity will not give you a chest pain.
There could be involvement of the pleura, sir, that can cause any chest pain.
When do you get involvement of pleura? How do you interpret that as significant? If a patient has an infective pathology, early pneumonia with pleural involvement causing pleuritis can give you rise to chest pain. Second, you thought your second diagnosis was tuberculosis. Okay. Why do you get chest pain in tuberculosis? When do you get chest pain in tuberculosis? Your third option was malignancy.
Yes.
Do you get chest pain in malignancy?
No.
Yes or no?
Yes, sir. Yes, sir.
It can happen.
Yes.
Right? So now with this background of the history, tell us your physical findings.
Yes.
Aspergilloma primary presentation is often hemoptysis. It's not necessarily you get black disease. That is more often the primary presentation is hemoptysis. They may get sometimes, but zygomycosis is more likely to.
Yes. On examination, the patient is conscious and oriented. He's thinly built and poorly nourished. He has pallor with grade 2 clubbing. His respiratory rate is 26 per minute, regular in rhythm, and saturation on room air is 95%, but other hemodynamic parameters are normal. He breathes through pursed lips, and there are nicotine staining of gums are present. His BMI is 14.5, which would make him underweight. Examination of the respiratory system. On inspection, 95%.
What did you mean by breathes through pursed lips? What are you trying to tell us?
Breathing through pursed lips, it is seen more commonly in emphysematous diseases, sir, where it can
COPD.
COPD.
So something similar to a pink puffer and a blue bloater.
Yes.
So pink puffer. So he probably has COPD as well.
Yes.
Yeah, that's what you're wanting to imply. Okay.
Respiratory system. On inspection, the trachea is seen to be deviated to the left side, with the prominent axillary respiratory muscles are prominent. There is asymmetry more on the left side, sir. Trail sensor. They can't hear you. Trail sensor.
Yeah. Don't be apologetic.
Trail sensor.
Trail sign.
There is asymmetry present in the form of left supra and infraclavicular hollowing. The apex is visible, apical impulse is visible, about 1 centimeter inferior to the left nipple. There are
1 centimeter inferior to the left nipple in a. I don't want to continue. It can be at the knee in a some female.
In the midclavicular lines.
When you said the trachea is deviated, why did you not talk about the apex also to tell the entire mediastinum is shifted? No.
Yes.
Both go hand in hand.
Yes, sir. Yes, sir. There are reduced respiratory movements on the left side, on the anterior and posterior aspect, appreciable on the anterior and posterior aspect. There is scoliosis present with convexity towards the right side and shoulder drooping towards the left side. The medial border of the left scapula is more prominent, but otherwise there are no scars, sinuses, or any local skin discolorations. On palpation, there is no local rise in temperature tenderness. The trachea is palpated to be shifted to the left side. The apex is noted to be in the 5th intercostal space in the midclavicular line. The respiratory movements are reduced on the left side as compared to the right, and tactile vocal fremitus is reduced over the left infraclavicular region and the axillary regions. Measurements: the AP diameter is about 17 centimeter and transverse diameter is about 22 centimeter. Circumference on inspiration it is 79 centimeters. On expiration it is 78 centimeters.
Doesn't mean anything to me. It doesn't mean anything to me because you have to compare the two sides.
Yes, sir. No,
you said the right and left. So the volume of the left chest is from what your description is less.
Yes.
Yes.
So you have to compare the two.
Yes.
If you tell me an overall dimension, it doesn't mean anything to me.
Yes. The right hemithorax on inspiration is 39 centimeters. On expiration, it is 38 centimeters. The left hemithorax is the same on inspiration expiration at 35 centimeters. Comparatively, it is lesser on the left side.
So it is 2 or 3 centimeters lesser.
Yes.
Just summarize that. Instead of going all over, you say the left, there is loss of volume in the left hemithorax.
Yes.
So don't waste time on all these things. So the loss of volume amounting to almost 2 to 3 centimeters less compared to the right.
Yes.
That's it.
Yes.
So we get a picture that there is something going on the left side. It's a chronic disease. There is loss of lung volume and the chest cavity. So we'll go on further. Then you had auscultation. No, the percussion.
On percussion, the right hemithorax is hyperresonant in all the anterior, posterior, and axillary regions. On the left side, the apical region is resonant, but there is dullness percussed on the anterior, posterior, and the axillary regions on the left side, sir.
No. Now you have to tell me. You said hyperresonant on the right side and resonant on the left side. Which side is the pathology, do you think?
Left side, sir.
Left side.
Yes.
So why is the right side hyperresonant?
So it could be due to compensatory expansion of the right lungs, sir, right hemithorax.
You are having rib crowding and everything, and yet it is resonant.
Rib crowding is present on the left side, sir.
That's what I'm saying, and it's still resonant.
No, sir. Only on the apex it is resonant, and the other regions it is dull, sir.
Okay. All right.
On auscultation, on the right side, vesicular breath sounds are heard. On the left side, there is tubular breath sounds heard in the infraclavicular, mammary, and inframammary regions.
What breath sounds?
Tubular, sir.
Tubular.
Bronchial.
Bronchial breath. Okay.
And also it is the same auscultatory findings in the axilla, sir. But otherwise, supraclavicular region on the left side, it is normal. Right side, it is normal vesicular breath sounds are heard, sir, on the right side.
No, they're making so much noise there. None of us can hear it.
The conference, they should all be made to sit in the front.
Okay.
Whole attitude is to sit at the back.
So summarize your auscultatory finding.
What we are getting interest? What Amit Tendulkar has to take interest in this work? We are bringing interest into your presentation. We can sit outside and enjoy and keep on chatting. You see, insulting to the presenters.
Sorry, we lost the trend. Okay, come back to the auscultatory finding.
He was talking. They should have a cabin outside for organization. Sorry, ductile vocal parameters and rib crowding. How we can have both together. If you don't know. Right upper quadrant eyeball reading not required.
I'd like to try, sir. Tactile vocal parameters.
Rib crowding is lung is
consolidated, sir.
Small or large?
Small, sir.
Small.
Yes.
Nothing to do with consolidation.
Yes.
Lung is small, loss volume. And now you are having, in addition, consolidation of tongue. Is it right, Shri Krishna?
Yeah, that's what I gather from the presentation. Okay, it's possible.
Good. Right.
Summarizing the auscultatory findings, sir. There are tubular bronchial breath sounds present in the left lower zones, mainly in the mammary and inframammary regions, but our normal breath sounds are present on the right side, sir.
Please use the word bronchial breath sound. Like it is an open invitation to ask you what are the types of bronchial breathing. You want to get into that MBBS?
Tubular, you will get where?
Where will you get tubular?
When the larger airways are patent, sir. And
in emphysema, you get tubular?
No, sir.
No, you're getting deeper.
So,
so just stick to, you got bronchial breath sounds.
Yes.
And you got dullness on percussion, Okay, and then there is collapse of the chest wall. I mean, chest hemi. So what is your inference?
It is likely a congestion collapse of the left lower lobe.
Collapse, consolidation, both can be present. Collapse, consolidation of the
Left lower
whatever area that you have, upper lobe or lower lobe, whatever this thing. So when will you get this both? In a long-standing disease process, which tuberculosis would be the commonest in our country. Can this be? Then you said there's an additional purulent sputum.
Yes, sir.
If you have purulent sputum, what else could you have expected in auscultation?
Crepitations.
Crackles, crepitations, okay, and postural variation.
Yes.
Was it there or not?
No, sir.
You couldn't appreciate.
No, sir.
If it is not there, why do you think it is not there? If you're thinking about tuberculosis. Does tuberculosis cause bronchiectasis?
Yes, sir.
It can, sir. It can, sir.
It can. It does most of the times. And can you have a dry bronchiectasis anywhere in tuberculosis?
Yesterday's talk.
Yes, sir.
Where? Why?
Sorry, sir, I'm not sure, sir.
Yesterday's talk.
Madam.
So dry bronchiectasis can exist with tuberculosis if it's blocking the part of the airway, sir.
No, don't guess.
What is the classic bronchiectasis that occurs? Bronchiectasis, I mean, tuberculosis affects which part of the lung?
Apical, sir.
Apical. Why?
So aerophilic tubercular bacteria.
Okay. So if it is upper lobe involvement and you get bronchiectasis there, why do you think it is dry?
The patient is sick and a specific form of bronchiectasis.
Giving you a clue. It's called, anybody else in the audience?
Bronchiectasis sicca. Why does it happen? Not because it is blocked. It's exactly the opposite. It is draining out immediately.
It's draining because it comes into the main bronchus and then it is expectorated out. So you may have copious purulent sputum as well as a dry this thing on the clinical findings. It's possible.
And you did not quantify the amount of sputum.
Like yesterday, I told you the color, quantity, the consistency, all that you should have brought in anyway. And postural drainage. And anything else you want to ask? Okay.
So do you want me to, I can quantify the sputum amount. It is around half teaspoon. It's yellowish in color, thick in consistency, foul smelling, sir. And without any blood tinged associated blood.
His sleep is disturbed?
Yes, sir, because of coughing is disturbed, sir.
Postural drainage during the time of any disturbance in this position?
Yes, sir. He says that if he's sleeping on his side, sir, his cough, his left side, if he's sleeping, because of coughing and everything, his chest pain occurs. So he prefers to sleep on the right side, sir.
That is unusual. That is unusual. You are saying the opposite.
Yeah. If you say that, that means that when he turns and keeps the diseased lung
above, he will be more symptomatic.
He will be more symptomatic,
right?
So he feels the pain is more. It's not because of any. Because of pain, he said so.
So even then, if you pain, if you sleep on the side of this thing, the pain will be less.
It gets splintered.
Okay. Anyways, all right. So with this you're done. You're done with the examination and physical finding. I mean history.
Yes,
so what is your provisional diagnosis?
So a long-standing chronic lung infection of most likely the left side, which is infective in origin, sir, and it can be due to multiple causes. Most likely, it looks like tuberculosis because of his primary positive contact, sir, and significant weight loss, sir.
76-year-old man, and his contact was his mother who in his childhood.
Yes.
You think that is significant now? I don't think that you can bring in that the history of point of contact in this point of time. Okay. So anyway, anybody can get tuberculosis. De novo, you can get tuberculosis, but history of contact and that causing tuberculosis at this age is unlikely. He's been symptomatic for the last 4 months. It's unlikely. Okay. So what do you want to do?
Sir, we will first do a X-ray chest, sir, PA view and lateral view, to see. And if he has previous any investigations, I would like to see those.
Very good. Very good. Does he have?
Yes, sir. He has his X-rays. He has from his previous admission, sir. Other things he does not have, sir.
Can we have it in a series, or do you have only the present X-ray?
Yes, sir.
Oh, good. Okay. So the one on the
That one is
21.9 and 28.
Yes, sir.
2. That is the recent one.
Yes, sir.
On the left side. Okay. Read.
Yes, sir. Sir, this is an X-ray. These are X-ray chest PA view, sir, with overexposed film, sir. Trachea is deviated to the right side. The CT
To the right side. What are morning? Everyone is thinking right.
About right and left.
Sorry.
It is as if the person is standing in front of you. That is the rule of anatomy. That as if the human is standing in front of you. So superior remains superior.
Which is
left
right,
remains
which is
left. Go there and touch.
Go touch right and left.
And tell
That
what
is
it
what?
is.
Or
Thank
so
you.
where is the trachea? Well, that is?
Left side.
Huh?
Left side, sir. Trachea is deviated to the left side, sir. CT ratio is 0.4, sir. Now commenting on the lung field, sir, the ribs, there's crowding of ribs in the upper zones on the left side.
In a thoracic case, you don't have to talk much different about the CT ratio. Your overall picture, it's grossly seen that there is loss of volume on the left hemithorax, right? And then there is crowding of ribs more so in the apical region than in the lower region. So you comment on that, and then come to the lung fields. In a thoracic case, you have to go from the lung and then on to the cardiac. Unlike in cardiac patient, you start with the heart and then go on to the lungs last. Okay.
Also, Sri Krishna, I want to ask you whether should she first present 2109 and then come to 2802?
Yeah, it's good. It's now that we have both the things.
Now we have got both the things. That will tell you the
progression of the disease.
That will bring you to the treatment also, if you know the progression. So first, please start the one on your left. Miss or my left.
Sir, it's a PA view of X-ray chest with the overexposed film, sir. With the there is a lung volume on the left side is decreased, sir. There is the rib crowding is there on the upper zones. Along with that, there is increased evidence of fibrosis in the upper zones.
Fibrosis is a pathology statement. What you see there is a radiological statement.
So pulling down of the shoulders acromion can be seen. The left clavicle is also pulled down in this, and that is seems like there is some sort of shortening is happening because of the underlying lung pathology. Along with that, there is increased, there looks like there's some sort of cavitary lesion in the upper side.
Where is the cavitary lesion in the upper side? Use the cursor.
It should be a stick which can be used for
this one. Okay.
Okay. No, you can't call it a cavitary lesion. It's a fibrous lesion. You can say that. Okay. What is more important that you should see when you're talking about the X-ray? You look at the CP angles, whether there is any fluid there, whether there is any pneumothorax. Okay. See that, and then from that compare this X-ray.
Is there a pneumothorax?
Yes, sir, on this side.
No. The first X-ray, old X-ray, in the upper.
What is there? Can you see the margin of the lung, and then where is the chest wall?
From here, I feel
yes, sir.
you are seeing a total lucency on that side of the.
Yes, sir.
Huh?
Yes, actually, pleural thickening is also there.
Sir, here, sir.
Pleural thickening, sir.
Sir.
That is pleural thickening. No? It is. That is pleural thickening.
See this part of the lung and
Yes,
see
sir.
this part of the lung. I feel a clear.
Small.
Yeah. But above there is pleural thickening also.
There is a small amount of pneumothorax, which you can say, but there is gross thickening of the pleura there,
Thickening is there.
which is much more marked on the
Second. It is.
So as compared to the old one, what has happened in the recent one?
So pleural thickening has increased, rib crowding has increased. There is now evidence of it looks like maybe it is going towards empyema on the this side.
To call it empyema, you must see a fluid level.
Yes.
Is it seen?
No, sir.
No,
Then
why do you
right
call it
to
an empyema? I wouldn't agree with that. You may be seeing that in a CT later on,
Yes.
but on these X-ray,
Yes, sir.
I will not commit for an empyema. Okay.
Is there any calcification of pleura in the recent X-ray compared to previous one?
Yeah.
Yeah, there is calcification.
Yes, sir.
The
Yes,
soft-
sir. Yes, sir.
The soft tissue shadow is increased.
Yeah.
So is it because of the recent X-rays, the soft plate, the softer plate as compared to this one? See this?
Yes, sir.
You can see the lumbar.
Another
number
yeah,
4 also.
another important thing is when there is a gross error, always cover the gross error and see the other thing. What is the most important thing in a lung case?
Opposite side of the lung.
That you have to comment.
Hyperinflated, sir.
And do you see any lesion there? See the second X-ray between the first and the second X-ray.
Yes, sir.
There is some lesion occurring in the right lower
Yes, sir.
right lower zone. No, here
Yes.
That is the cause of concern. Every
Yes,
time you
sir.
should always say, what is the residual lung that
See,
I'm going to-"
remember, he's a 76-year-old person.
Yes.
So you will have calcification of the costal cartilages as well. So keep that in mind. Okay.
Yes.
It will be there on both sides.
Both sides.
The main thing that you say is that the disease has progressed on the left side. I mean, on the recent X-ray, there is gross increased loss of volume, and there is the CP angles look okay. There is no gross blunting of the CP angles. So there may be a fibrocavitary lesion on this X-ray alone, a fibrocavitary lesion of the left upper lobe with calcified pleura. There is.
There is. And actually there is some soap bubbling there, no?
There is calcified pleura.
Pleura. And then some soap bubbling is also seen there, multiple soap bubbling there. Yeah.
Low down also, and you can also see some amount of calcification of the costal cartilages. Okay. Now on this X-ray, do you think it correlates with your clinical diagnosis?
So I'm suspecting a
Yes.
chronic infective
So
condition.
maybe.
So it is.
So what is your next step?
So my next step is blood investigation and CT, sir.
Blood investigation will tell you what? For
The
what?
blood investigation, because if it's an infective pathology, there'll be WBC count increase, there'll be increase in the CRP.
Do you think it's an acute lesion?
No, sir, but there is an acute exacerbation of a chronic condition, sir.
Okay.
Would you not like to do a sputum examination?
Yes, sir.
What else sputum examination would you like to do?
Sir, I want to do it for tuberculosis first, and along with that, I'll be doing it for bacteriological cultures, sir. Along with that, sir, I want to do a bronchoscopy and take washing from there as well as for cultures.
What is the saturation of this patient?
Sir, 95%.
See, before that, you should have told me that you will do a sputum examination for bacterial culture, tuberculosis, and
Fungal.
fungus. It's important because your initial, he said that it could be an
be
aspergilloma.
aspergilloma and all.
Started off with aspergilloma. So you see all these three things, and then, okay, it may be positive, may not be positive. It's all right.
Jaydev, why did you say entertain aspergilloma directly in this X-ray? Like diagnostically, you felt that it was an aspergilloma.
What's the classical sign of an aspergilloma? And why does it occur?
Sir, air crescent sign can occur on the CT, sir. And because of the fungal ball will move, and along with that,
Not on the CT, even it can be seen on the X-ray as well. Okay. It is usually seen as an opportunistic infection in a chronic cavity, which is thick-walled. Okay. So tuberculous cavities are generally thick-walled, unlike a lung abscess, which could be just a thin-walled if it's an acute process. So tuberculous cavity with a crescent sign, which again moves.
You take the X-ray in
different places, but nowadays nobody does that. But once you see an X-ray and a CT scan, you see the classical crescent sign. Nobody does all these maneuvers. It's not necessary. So a crescent sign seen in a chronic cavity will tell you that it could be most probably a fungal ball. That is commonly an aspergilloma. The other thing that in the present time maybe or this thing is that you should also keep in mind mucormycosis. Okay, because of COVID. Right? That incidence has increased in the recent past, but that may not be so relevant right now, but you must think about it as well.
That gives more of a black spotted sputum. Mucormycosis.
Okay, CT, we have a CT?
CT? CT.
Can we enlarge it a bit?
Can we enlarge it?
Zoom. Or they put it into a PPT. Go there and you have
Okay,
to track.
anyway, you have seen this?
Yes, sir.
You have seen this. Okay, describe it.
So mostly it is correlating with all the findings which I found on the X-ray, along with pleural thickening. I could feel that there is a split pleura, sir. It looks like in one of the in the film that there is split pleura, sir. So I would consider it as a chronic infective pathology with an acute exacerbation.
Whole concept of CT is identify lobar affection.
And sir, I feel it's in the upper zone, sir. The cavity
lobe.
There is no
After
upper
CT,
zone
if you
of
again
any
start talking zone, is useless. Then no need of CT. So how do you decide lobes on CT? You trace what? You
oblique
trace
fissure.
what?
Oblique fissure, sir.
Trachea.
Okay, sir.
You trace trachea, then carina, then bronchus, then upper lobe bronchus. Like that, you have to trace. Okay?
Yes.
Sir, am I right?
Yeah.
Please keep on correcting me. So trace the trachea from this side, which is, what is this side? Left side or right side?
Sir, right.
Right side. See?
Sir, right.
CT is from the head is from which end? CT, chest and abdomen is from
Anyway,
which end?
start trachea.
Okay, let's not so much of time here because
top left, top, starting from top, from left, this is left, my side is left, second plate, down, second plate, left, second row. Arey Baba. Yeah, this is first. Can you see the carina is forming?
Down
Okay.
below. Carina down below, sir. Down below. Carina is at the
Here, sorry.
Carina
So what is that shadow next to the trachea?
That's the probably the esophagus.
Esophagus. I'm sorry. My mistake. This is a carina. Okay. Then carina fully formed. So before carina, fully forming. What has happened to the lung architecture? Yeah. Now you talk in terms of lobes. Don't talk in terms of zones.
So there is a fibrocavitary lesion of the upper lobe, left upper lobe, with a thickened pleura and causing a.
Yes.
In this, you can see an empyema cavity, probably. Okay.
This one?
Yeah. There's a pneumothorax with a little bit of fluid level in between, so that could be possibly a empyema, a secondary empyema is there. Okay.
And this is the lower lobe bronchus.
Yeah.
Okay. And the lower lobes looks okay, or it is also severely diseased.
No, lower lobe looks okay. Now, what we want to do?
Anything else you want to see apart from lower lobe?
Don't forget to tell the normal
No,
right lung.
normal right lung.
Right lung is on this side.
Yes.
Okay.
Always look for the normal lung.
Yes.
All right. What's your next step?
Sir, bronchoscopy, sir.
Okay.
What?
Why?
Because I want to confirm my diagnosis. If there is a positive culture on that, I want to start the appropriate antibiotics, sir, before attempting any other surgical modality, sir.
What else you want to see on the bronchoscope?
Sir, Sir, I want to see whether there is if there's a suspicion of aspergilloma, I will. No, sir. No, sir. No, but I want to confirm with the cultures, and sir, I want to get the cultures from the. Okay.
What will be that minimal empyema on the lateral side of the lower lobe?
Sir, cavitary lesion, sir.
Some decortication.
In the cavitary lesion, what do you want to see? Are you wanting to operate on this patient or not?
Yes, sir. First, I want to optimize him. Then I want to go in for surgery, sir.
So, in your bronchoscopy, what is important for you?
Sir,
apart from culture, okay, we have done a smear, culture, this thing, whatever, you have found maybe aspergilloma. Many a time we don't see the fungal elements on the sputum or the bronchial wash. It doesn't matter. So he's got a destroyed left upper lobe. Okay. Now, what is more important?
Sir, normal architecture, how much is preserved and how much is...
on the bronchoscopy. You can't see that.
Bronchoscopy. Why do you do a bronchoscopy? Most important.
First step in prevention of bronchopleural fistula.
You want to know whether that bronchus, wherever you are going to section the bronchus, is healthy or not. Okay. Whether there is been an long-standing, the many a time you have a long-standing intrabronchial foreign body giving rise to all these things. Okay, whether there is anything that is inside the intrabronchial pathology. Okay, those are the two things that you have to know. And supposing there is a bronchial involvement at the site of your left upper lobectomy, which if you are planning a left upper lobectomy, then you have to make sure that that bronchus is going to be healthy. Otherwise, as Vinayak said, is prone for fistula. Okay. So bronchoscopy. What next?
Respiratory parameters have to be evaluated. FEV1 for this particular patient. DLCO is test. Pulmonary function tests have to be done for this. If the yes, sir?
Have you done anything?
Did you do any clinical test?
A 6-minute walk test can be done in this case, but the patient was very breathless in the morning.
Commonly done. More specific than 6-minute walk test today.
So stairs.
Stair climbing test is now recommended. Not there.
No. First of all, let us have 3 questions. Does this patient require surgery?
Yes. No.
Maybe, yes or no, or maybe?
Some maybe.
Maybe. Okay. Does it easy fit for surgery?
Not yet.
We don't know. Not
Yes,
yet.
sir.
And are you going, what surgery are you planning, and are you going to improve his lifestyle from what it is now?
So we can do decortication along with placement of 2 chest tubes and drain away the empyema and wait for the lung to expand while giving improvement in the general habitus of the patient along with antibiotics that will improve his and wait for the lungs to improve. He's a 76-year-old. I don't want to go in for a lobectomy or
True.
anything in this.
One, you don't know whether
Is it possible to reach the empyema space blindly or CT guided?
that is difficult because this is a completely crowded. You will not even be able to get
It's
into
not
the.
easy to
It's not.
tell
It's
that
not.
I will insert tubes.
No, you cannot see. The thing is, first, as you rightly said, this patient may require surgery. Looking at the history and your physical findings and the age of the patient, I am not sure if he is going to be fit for surgery. Secondly, the important technical problems that you would face is there is a calcified pleura, there is a grossly destroyed upper lobe, and you don't know what is the fissure may not be completely plain, this thing, and the whole this thing is distorted. I'm not sure whether I'll be able to save the entire lung. So this is not going to be very easy surgery. And third, I'm not sure whether I can promise to give him a better option after the surgery. So if you told me that I may not want to operate on him, it is perfectly all right.
If you want to do any something to this patient,
Because
what you want to do?
If all these things come theoretically, he's fine, he's fit, what else you want to do? You have to also look at his heart. You also have to, don't forget, in a thoracic patient, you must do an echo. As against a cardiac patient, most of them are smokers. People don't do a PFT in their cardiac patients. All right. And that causes prolonged ventilation in your post-op period. Most of your cardiac patients. That is it. So always remember PFT in a cardiac patient and echo in a thoracic patient. All right. These two have to be done. And
Instead of 76, his age was 56. What operation will be done? Look there and talk.
Fit 56.
So,
Fit 56, 46.
His
decortication and weight. Decortication and weight, sir.
Not upper lobectomy.
What
No,
about
sir.
the lobe?
Why?
Sir, empyema is there, sir. The stump will get infected and that will cause more problem. First, I'll recruit the
But
lungs.
if you leave that lobe in a 56-year-old fellow, he will cause another empyema.
You are possessed by that empyema.
You cannot save that. You
There is
have
already irreversible damage to the lung.
Yes, sir.
So we have to remove that part of the lung.
And even the decortication over the lower lobe. See that lower lobe thickened pleura, it is extending up to, continuing. There it has disappeared. It's continuing even there, lower lobe.
Okay, technically, if supposing you want to do, as sir said, you have to do a lobectomy, you will do a lobectomy. What are the precautions you will take to prevent a BPF in this patient?
So the stump has to be closed in a way where the knots are on the membranous side.
Sorry?
The knots have to be placed on the membranous part of the
You are going to be using knots.
stapler can be
What would you prefer? Present day?
Stapler.
Present day, how do they close the bronchus? Yes, in my days, yes, I still did hand sewing and suturing. Knots will be out on the outside. A 2-layer closure I used to do. But anyway, nowadays everybody does a stapler, right?
Yes.
What are the precautions?
So two ICDs have to be placed, sir.
No,
stapling precautions.
Bronchial closure precaution.
You are stuck to those 2 ICDs and empyema.
Bronchial closure, you said, okay, we may agree stapler. What stapler do you know? Have you used a stapler? You have seen a lobectomy? No. So there is no point in asking any. Anybody else? Anybody else?
How do you close the bronchus?
So before that, pulmonary artery.
No.
Where do you look for pulmonary artery?
That whole system is all anatomy is totally distorted.
Another organ which I am scared is the esophagus.
The thing that I want to ask is, while doing this lobectomy, the patient desaturates. While doing the lobectomy, whatever you're doing, the patient starts desaturating. The patient's saturation becomes, if it was what, 95. You've intubated, whatever you've done, 95. Now it has suddenly become 85. Then anesthesiologist is telling hemodynamic instability has started occurring, 70, 75. At arrest.
I am suspecting a pneumothorax
Where?
on the opposite side, sir. So I'll put a tube.
Where is the pneumothorax going to occur in the opposite side in this case? Show me.
Why do you think it will happen?
In this case. Specifically in this case, we are talking of a pneumothorax.
Because of rupture of some bulla in that lung?
Opposite lung bulla? No.
Oh,
no.
So the answer was correct, but the cause
is
of
wrong.
pneumothorax is wrong.
See, there is compensatory hypertrophy. You only said that, no? Compensatory hypertrophy of the right lung. It is going across the midline. So when you are doing, you must be careful to make your thoracotomy more posteriorly rather than, and not open the opposite pleura. If you inadvertently open the opposite pleura, you'll end up with the...
Then what do you do? If the pleura, you have found a rent there, what do you do? Saturation 75, with hypotension occurring.
Open it widely. So
Open that thing widely.
Convert it from tension pneumothorax to an open pneumothorax.
Then you can put
And with anesthetic ventilating, it will be less problematous.
And then you put in a tube. Don't forget to put in a tube on the opposite side as
at
well.
the end of the case.
So you have 3 tubes.
No, you have 3 tubes.
Enjoy.
Two.
Two on empyema.
So coming back to bronchial closure,
yes, sir.
You have to make sure that you don't denude the bronchus by your cautery, all right, or dissection. You must leave as little stump as possible, easier said than done on the left side, because it will be buried under the arch of the aorta and the AP window. So it's technically very difficult. Third, you have to put your stapler as close to the carina as possible, not leaving a big stump. Fourth, you should have planned beforehand to raise an intercostal muscle flap.
I want to ask you one thing. In this case, when you open the chest, how easy is it to open the chest? And what will you do? Because she
has not. Have you assisted any thoracic patient?
You've done your rotation in thoracic? No. Okay.
If
Anyone
you
else
stay like
has
that,
done a rotation in thoracic?
You may be told to go, assist and then come.
Many a time you may have to excise one rib to get into the chest itself.
Because it is so crowded. Number one. Number two, as I said, you have to have planned your intercostal flap if you are planning to put an intercostal flap before you even put the spreader. Otherwise, you'll crush everything.
Just like bronchitis sicca, this being an upper and lingular segment together. So you think that stump little long will do?
No.
Because it will naturally drain?
No.
No?
No. The minute you leave a long stump,
it
forms a sump and
but it is upper.
No, but still it's
devascularization.
Okay, then the stapling, we have not answered. How will you staple the anterior wall coming to the posterior or the superior coming to the inferior?
It's like this or like this?
Like this or like this.
Anterior coming to posterior.
Unfair question for her.
Or
she has not seen. Who has seen? Come tell. Come up. Tell it. They have not done their thoracic rotation. Still second year.
Put the stapler so as to have the compression between anterior and posterior walls.
Why?
Sir, because we don't want to denude the stump of the remnant vasculature.
See, the anterior wall is cartilaginous and the posterior wall is membranous. So the
Yes,
two
sir.
come together.
Yes, sir.
And what stapler do you use? You have three colored staplers. One
Purple
is white.
stapler.
White is for vascular structures like the PA or the pulmonary vein. And then you have green, which is for bronchus. And then you have blue for the pulmonary parenchyma if there is incomplete fissure.
Standard code.
Standard code.
See, this is the importance that when a lung resection is being done in our hospital, you should, when they come from Kidwai, you should see these things.
White, blue, and green.
White is vascular.
White is vascular. WW. White is vascular. Okay. Green is for bronchus. And then blue or gold or black you get for parenchyma depending on the thickness. Okay.
It has taken away the charm of lung surgery questioning.
How to close and
And how do you test for the bronchial stump? That still remains.
Sir, double lumen tube we'll put, sir, and then we'll
Double lumen tube has been put at the beginning of surgery.
So we'll fill the cavity with saline and ask the anesthetist to give positive pressure ventilation.
How much?
Don't know, sir. Sir, I don't know, sir.
Any positive air will come out.
How much is it?
10
centimeters.
10 is always a
10, 20, 30, 40, 50.
Since yesterday 10%,
yes.
Incidence 10%.
What is the thing that they do? They bag and they be looking at the monitor, no?
You inflate the remaining lung and hold. And then there will be water or saline on the stump. It will look for bubbles coming out.
They purposely raise it to 30.
If you see bubbles, you may have to close it again with a suture.
30 millimeters the minimum they put it. 30 millimeters.
From where else? From where else bubbles can come?
Where else in this case, especially?
This case.
This one with the ICD, 2 ICD. 3.
There's a
opposite lung.
Opposite lung.
And this patient lower lobe will be stuck. So lower lobe also will be raw.
You'll have to probably
So you'll have to find out from where exactly bubbles are. What sutures you use after stapler?
I mean, just for one small.
Just simple interrupted suture.
A left-sided tube or a right-sided tube? Which tube are you using? Double lumen tube you said?
Sir? Yes, sir.
There are separate tubes, no, for right side or left side, or not?
They don't know.
Same aisa dalega to left.
Is there a left and a right DLT?
Yes.
Huh? Yeah. How does the left and the right difference? How do you look at it and tell?
What is Murphy's hole?
Not heard of Murphy's hole.
Knowledge of anatomy? Bronchial anatomy?
In a normal ET tube, is there a Murphy hole? Have you heard of a Murphy hole? Oh, sir. Pediatrics. Oh, sir.
No. It appears that none of them have been exposed to thoracic
We
surgery.
had a big class on the national board about this.
Thoracic surgery.
Sir, there are two types of DLTs, sir. There are two types of DLTs, one to the right and one to the left. Two DLTs are there, right and left.
Louder, speak louder.
Two DLTs are there, one right side and left side. Depends on the longer, the lumen which enters into the. There are two holes around the DLT. The one which is more distal, that is considered to be the right side or the left side, sir. They selectively ventilate the right or left.
Okay, which lung can you isolate with which tube?
He's wrong.
With the right side DLT, you can.
We want to know which is right and which is left. Oh, so I will take a DLT like this and bend it like this and it will become left. And if I bend it like that, it becomes right. Huh?
So they don't know, so we have to forgive them. Yeah, I don't know why did you not attend the class? There was 2 lectures on this in National Board on Wednesday from 6:30 to 7:30. And I took the class.
Spirit.
उसी को बुलाओ साहब. So call him only to clean.
Ask him to come and work it.
तो कोई दाग कभी नहीं जाते सर. Maybe they're telling us it's lunchtime.
How does the tube look
Question
like?
is, ask is, how do you identify right side
They have not seen, they have not yet done their lung posting. So next somebody come know has done lung posting.
So they have the double tube here.
Yeah.
Just do totally with bronchial
Anatomy.
We don't know. Bronchial anatomy not known is absolutely unheard of.
The tubes all have one Murphy's hole.
ये बुरा वर्ड से वो नहीं आएगा तो भी चलेगा. Another feeling I am constantly getting, it is we are interested in learning and students are scrolling their mobiles. And as if one case presentation means, हो गया, full, you know, after certain acts, you feel, like that they are sitting on the backside, talking, chatting, scrolling mobiles.
Thoracic surgery is much, much more difficult than cardiac surgery. Remember that first. That is why many people don't do thoracic surgery. The minute you open the pericardium, everything is in front of you.
You put on pump
But,
and do whatever.
but for thoracic surgery, if you want to dissect this lung, it is going to take you 2.5 hours to even identify what is what.
Opening the chest itself is
Opening the chest is the biggest pain in this case.
So don't take it lightly. And then you are appearing for a cardiothoracic exam, all of you. So you will have vascular, they might give you a thoracic outlet syndrome at the most, or a carotid endarterectomy, maybe. Otherwise, they don't give you the other things. But you will have an empyema, you will have a lobectomy. You must know all the steps of lobectomy, how you go about it for each this thing, or a pneumonectomy, right or the left pneumonectomy. Then you must know the approaches to the chest, different incisions to the chest, and then you must know what to do in a mediastinal tumor, what to do in a thymus, what are the pre-op management or stabilization in a patient with myasthenia gravis. And you must know the various incisions and also finally those cases where you will need SCPB standby. Okay. The present thoracic surgeons don't do that because oncologists and the thoracic surgeons don't do that. All of us are cardiothoracic surgeons, so we know how to run a pump. All right. So we know when to use a pump. This generation of surgeons is sort of gone nowadays. Many places where they have huge tumors in a cancer institute, say for example Tata Memorial, they don't have an access to the pump, so they don't know what to do. They do that.
They come to our hospital and do it. Lung surgery is done in our hospital whenever there is a potential for.
So these steps, operative steps, maybe if there is a chance in the evening, we have something for the operative steps. Maybe we could talk about that in the evening.
He hardly any talk on operating.
He wanted operating surgery as a session.
See, I'm amazed that none of you have had a thoracic surgical exposure. You have not seen a thoracic case. Have you? How many of you have seen one?
Then you should all answer, no?
No, why are you keeping quiet? What have you seen? What cases have you seen?
We do lobectomies, we do segmental wedge resections, wedge resection and.
Then why are you keeping quiet when I ask you questions? It's unfair. This girl has not seen a case at all. It's unfair to ask her any questions. Anyway, if you all don't participate, this whole this thing was a waste. This whole thing was a waste.
The person who did thoracic rotation should have presented this case, no?
Anyway, I think we have exceeded our time. Any comments, Kumar? Anything?
We're fine with presentation, only surgical part.
surgical part because they're not, they don't know.
They have to, those
That is the anatomy of pulmonary artery. How will you search? Where will you search? This has no excuse. Right pulmonary artery, left pulmonary artery. Chalo, Anand.
Thank you.
Thank you.
I have one question again. In any lung resection, what is the most important life-saving step that you have to do while doing a lung resection? What should you isolate? Isolate.
I also don't know.
I'm telling the pulmonary artery should always be kept isolated in when you are doing any resection. So that if you have catastrophic hemorrhage, you should be able to nail.
Remember the pulmonary artery is the most delicate structure in the entire body.
Most unforgiving.
And in the presence of inflammation, etc., it is absolutely treacherous.
And I will tell you, I learned it very early because one day I was doing a left lobotomy in my as a PG and it tore and then I had to come and clamp the pulmonary artery and I never forget that in my dying day.
No,
I'm not okay.
But most of you will be dealing with constrictive pericarditis. You start with a LP, go around all over, release the entire heart, and by the time you come to the pulmonary artery, all of you will be fatigued, and that is where the disaster happens.
And you immediately enter a wrong
lane and
that is where disaster
and in any bite will only tear.
Okay, one last question for the boys. On the boys, say tuberculosis affecting the upper lobe. How does the AFP vascular go to the upper lobe? Go and find out.
How does it go to the upper lobe? I want to know. We read it up.
Wonderful lunch break.
We'll resume next session at 2 o'clock.